श्रीकांत लाईव्ह सुरू झाला. हॅलो. ओके ओके, मी मेसेज टाकून देतो सर. A very good morning to one and all. I, Dr. Prasanna Dahake, Associate Professor, Department of Pedodontics and Dentistry, College. All upon we are start program. I will be link this to our lecturer, Dr. Poonam Madam, for the program.
Thank you, sir. A very good morning to all. I, Dr. Poonam Gavli, welcome all delegates, speakers, and participants. It gives me a great pleasure to extend a warm welcome on behalf of Department of Pediatric and Preventive Dentistry, MIDSR Dental College, Latur, conducting a wonderful CDE program on strategies for management of developing malocclusion. Now, we will start our inauguration with the World Peace Prayer.
सर्वं जगत्यां जगत् तेन त्यक्तेन भुङ्जीथा मा गृधः कस्यचित् धनम् भूर्भुवस्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो न प्रचोदयात् सर्वेऽपि सुखिनः सन्तु सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखमाप्नुयात् शान्तिः अन्तरिक्षशान्तिः पृथिवीशान्तिः आपशान्तिः औषधयशान्तिः वनस्पतयशान्तिः विश्वेदेवाशान्तिः ब्रह्मशान्तिः सर्वशान्तिः शान्तिरेव शान्तिः सामा शान्तिरेधि शान्ति शान्ति शान्तिः.
Thank you. Now I hand over mic to Dr. Yogesh Kare, who is HOD, Professor and PG Guide at MIDSR Dental College, Latur. Dr. Kare is working in this renowned institute since 16 years. He will have a brief introduction to our CD program. Over to you, sir.
So your audio is not available since you are muted. Yeah.
Is that clear?
Yes.
Yeah. Good morning, one and all. I'm Dr. Yogesh Kare. It's a true pleasure for me to welcome you all on behalf of the organizing committee to the first CD of this academic year, conducted by the Department of Pediatric and Preventive Dentistry, MIDSR Dental College, Latur. I'm very grateful to our visionary patrons, the founder president of Myers MIT Group, Dr. V.D. Karad sir, our executive president, Sri Rahul Karad sir, executive director, Sri Rameshappa Karad sir, Dr. H.T. Karad sir, and of course our principal and the chairperson of today's program, Dr. Suresh Kamble sir, for encouraging and supporting our endeavor. It's an honor to welcome our esteemed speakers, Dr. Umal Doshi, Dr. Veena Arali, and Dr. Harsimran Singh Sethi, all the senior delegates, the colleagues all over India to this learning initiative. I should also welcome our MSDC observer for today's session, Dr. Shailesh Wange, who will be overseeing this session by our department. I'm glad to state that MSDC has accredited our session and awarded 3 credit points to today's session. So welcome to today's session, Strategies for Managing Developing Malocclusion. As we all know, pediatric dentists are usually the first to detect child's malocclusion, and having a strategy to manage these problems is an integral part of comprehensive pediatric oral care. If not treated, children will outgrow the majority of these issues and problems often become worse over a period of time. It is most effective to treat these conditions in primarily or early dentition, early mixed dentition to reduce severity of dental and occlusal problems and avoid future treatment complications. Early orthodontic treatment also has potential to correct problems in skeletal growth and may reduce the need for extraction of permanent teeth during phase 2 treatment. Perhaps most importantly, these interceptions can promote child's self-esteem. The comprehensive management of early malocclusion in children and adolescents must take into account dental, skeletal, soft tissue problems and their relationships. The clinicians must develop a thorough diagnosis, a definitive treatment plan with clearly set goals. Common orthodontic problems in children include dental developmental related problems such as crowding, missing teeth, supernumerary teeth, diastema, anterior posterior crossbite, and so on. Whereas skeletal developmental related problems such as developing maxillary excess or deficiency, mandibular prognathism or retrognatism, or a combination of these two can exist. Now, different treatment modalities can be categorized accordingly, from a simple space maintainer to myofunctional appliances to advanced interceptive orthodontic options. So today in this CD, we would like to try and learn more about some of these two treatment modalities. The first session on interceptive orthodontics would be an interesting one to learn from Dr. Umal Doshi, who will be our first speaker for the session. Dr. Prasanna would introduce our first speaker, Dr. Umal Doshi. Prasanna, sir, over to you.
Good morning, respected dignitaries, respected HOD sir, and respected speakers. On behalf of Department of Pedodontics and Preventive Dentistry, I, Dr. Prasanna Dahake, am now introducing Dr. Umal Doshi. Dr. Umal Doshi has completed his graduation with gold medal from Government Dental College, Aurangabad in 2004, and he has completed his master's degree in orthodontics with the certificate of merits from Vice Chancellor of MUHS Nashik, and the college from which he has completed his post-graduation is GDC, Government Dental College, Nagpur in 2009. He is recipient of the George Jacob Award for Best Clinical Innovation from Indian Orthodontic Society for 3 times, that is in 2010, 11, and 13. He holds an Indian patent for magnetic appliance for treatment of skeletal open bite. He is fellow of World Federation of Orthodontics, and he has more than 35 publications in international and national journals. Right now, he's serving as assistant editor to the Asia Pacific Orthodontic Society Journal, and he is on peer review board for Engel Orthodontist, European Journal of Orthodontics, Progress in Orthodontics, Dental Press, Journal of Orthodontics, JIOS. Dr. Umal is right now working as associate professor at CSMS's Dental College, and he will be speaking about interceptive orthodontics related to the today's topic. Now I hand over this mic to Dr. Umal Doshi to start with his session. Thank you, sir.
Audible?
Yes, sir.
Screen is fine.
Yeah, screen is visible, sir.
Yeah. So good morning, all. First of all, thank you, Prasanna, for this wonderful introduction of mine. Now, I would like to thank the organizing committee, that is the Department of Dental Dentistry from MIDSA Dental College. Special thanks to Dr. Professor HOD Yogesh Kale sir, Professor Dr. Dalpe sir, Prasanna, all the faculty members, trustees, principal from the college for this wonderful initiative. Now, this topic of developing malocclusion has often been neglected. So today's CD will be trying to focus on certain guidelines that one can follow in the clinical practice. The only thing is the today's audience, I think, is a mixed audience, that we have some clinicians, some interns, we have some PGs from ortho as well as from pedo. So I'll try to focus on the presentation so that everybody will get some clinical points from this presentation. Now, the topic that I'll be talking on is the interceptive orthodontics, and as I said, I'll be talking on more of a general guidelines that you can follow in the practice. Now, it has been said by Desiderius that prevention is better than cure, but unfortunately, especially in India, they're still lagging behind in the principal treatment strategies that one can adopt, that is a prevention of any underlying disease. So, because of this difficulty in achieving the prevention, in India, we have that almost 80% of children under 15 years have dental disease, and almost 40% from those suffer from the malocclusion. So it is quite a high number. Orthodontics in general, we have classified it as a preventive, interceptive, corrective, and surgical. For the corrective and surgical part is basically in the adulthood, in the non-growing patients, while the preventive and interceptive part is basically in the developing dentition, that is in the deciduous dentition, fixed dentition, mid dentition, and late dentition. If you see the definition of preventive orthodontics, it says that these are the actions taken to preserve the integrity of what appears normal for the age. So certainly at this age, malocclusion has not been developed. Okay, so any measure to preserve the integrity, what appears to be normal. Now, for this to be taken into consideration, one should have an idea what is normal for that age. Okay, for any clinician, for any dentist, something like or any PG also, basically understanding the basics of growth and development, especially regarding the jaws as well as the dentition, is of prime importance if one has to adopt the preventive and interceptive measures. So the next is interceptive orthodontics. Now, it is the phase of science and art of orthodontics employed to recognize and eliminate the potential irregularities. Just focus on these two words, that is recognize and eliminate. So what does this mean is, it includes both. One has to, based on his or her clinical acumen, to recognize the problem. And once we recognize the problem, and once we diagnose the case, then we have a proper treatment plan with which we can eliminate the potential irregularities. That is the reason why most of us, anybody who is teaching in the profession, we usually the PGs stress more upon diagnosis and treatment plan, because that is the base on which we will be providing the best possible evidence-based care. Now, what is the need? Ackerman and Profit said that almost 50% of the malocclusions can be corrected in the primary to mixed dentition. The article by Al Nemer and Richardson says that almost 1 in 3 community patients, there was a need of interceptive orthodontics, but only 20% got that interceptive measures. So it is quite startling to see that almost all over the world, the measures of preventive interceptive measures are still lagging behind. Timing obviously depends upon what will be the measures that you will be proposing, as well as based on the dental and the skeletal maturity. Okay, so there comes a first visit to the dentist or orthodontist. Indian Orthodontic Society recommends the first visit to any dentist or orthodontist at the age of 7 years. Why I'm stressing about only dentist also? Because in most of our Indian rural areas, there is still possibility of any orthodontist or orthodontist. So general dentist is the one who will be visited first. So what we recommend is to first visit to any dentist at least at the age of 7 years. Okay, so why there is a need of interceptive orthodontics? Basically, interceptive orthodontics will try to reduce the detrimental effects of enforced tooth loss. They can be accidental extraction of 6. Some dentists do that sometimes, or they can be need of extraction of permanent molars also because of badly carious teeth. They can be traumatic loss of incisors. So it will reduce the detrimental effects of all these early loss of deciduous or the permanent dentition or permanent molars. It will avoid the trauma to the incisors, especially if you look at the functional appliances. One of the basic indications for functional appliances nowadays, what we consider is one is to improve the self-esteem, obviously, and obviously the second thing is to avoid the trauma to the upper incisors. Because as we know, in class 2 division 1 malocclusion, there are prominent incisors. Okay, so any interceptive measures by using the functional appliances will reduce the chances of trauma to the upper incisors. Third is it will reduce the complexity of the treatment in the second phase. And lastly, if at all the habits can be stopped or habits can be corrected, it will prevent this untoward effect over a period of time. So these are the reasons why we should practice the interceptive orthodontics. And obviously, these will be more helpful for certain strata of population, especially handicapped children, physically, mentally disadvantaged, medically compromised, children with left lip and palate, and certainly the areas wherein the specialized services of periodontists or orthodontics is not available. Okay, so these are the special groups for which definitely one should consider the interceptive as well as preventive measures. Now, theoretically, these are the basic 7 procedures that one can carry out in the interceptive orthodontics, that is serial extraction, space regaining, correction of cross bites, oral habits elimination, muscle exercises, removal of hard and soft tissue impediments for the eruption of dentition, and interception of the developing skeletal malum. Okay, so I'll be focusing on the certain factors that will not be covered in the future lectures. Let's see the points that we can take home from this presentation. Now, before going into details, I think, as I said, one should have a thorough knowledge of eruption timing and sequence. I think most of us, over a period of time, once we cross our PGs, we go into clinical practice. These are the simple, basic things. Sometimes we miss out, and because we miss out on these simple things, we are not in a position to diagnose it properly. One should have this knowledge of sequence of eruption. That is, in primary dentition, it is ABT, CE. 6 months to 2.5 years, we expect the dentition to complete. Permanent dentition, special area to be observed is in the maxilla, the canine erupts after the premolars, that is the first premolar, while in mandible, the canine erupts before first premolar. This is a clinically very relevant difference in sequence in maxilla and mandible, with which we can diagnose certain malocclusions, especially related to the irregularities at the critical period of time. Now, why it is important? The basics are quite important again as regarding the eruption timing and sequence. As said by Dr. Broad in 1941, facial and dental patterns get established as early as 3 months. Completely gets established at the age of 4 years. So definitely, if you know this basic knowledge of development of jaws and dentition, it will help in your diagnosis as well as in your treatment planning. Now, anybody who is practicing over the years, PGs, we have a lot of faculty members who are practicing more than 10, 15 years. They will definitely appreciate that nowadays, in last 5, 10, 15 years, we are observing the malocclusion trend is getting increased, which was not there in the earlier generations. Okay, so can we, the reason that for this increasing number of malocclusion, can it be because of evolution? Now, evolution did not always be good. Okay, so this was an evolution of a man, but nowadays what is happening is this, and ultimately it lead to this. So ultimately, evolution did not always be a good thing. Certainly, sometimes similarly, what we see in the dentition also, it can be bad also. On the left side, if you see this figure, it is a skull of a Neanderthal. If you see the arch width, it is very wide arch, nicely aligned teeth, as well as there are all the erupted molars. In fact, there is slight space distant to the erupted third molars also. And on the right side, it is a recent population of a photograph. You can see there is a lot of crowding, V-shaped arches, deep palate, molars are yet not erupted. So, what is happening is because of evolutionary changes, because of a different diet that we have, the number of malocclusions are increasing. That is the reason why one should have a basic knowledge of growth and development regarding the jaws as well as dentition. Now, if you know this, the basics, definitely one is in a position to diagnose what we call it as a self-correcting malocclusion. So what is self-correcting malocclusion? It is an aberrant look of dentition that usually the parents are bothered about, but it will get corrected over a period of time without any interceptive measure. That we call it as a self-correcting malocclusion. So if any undergraduate or apprentice who has a good knowledge of basics, definitely he or she will also be able to understand this concept. And if again there is a some problem in diagnosing, one can have a communication with the specialist. Okay. So first is physiologic spacing. I think everybody has observed this. It is usually normal and desirable. Again, there are some concerns from parents that there is a lot of spacing between the dentition, but one has to explain to the parents that it is a normal thing, physiologic thing, and it will be quite helpful once the permanent dentition arrives. We know this that it will be helpful for managing the increased size of the upper permanent incisors, call it as incisor liability. There are some spaces distal to the lower canines and mesial to the upper canines, that is deciduous canines. We call it as a primate spaces, simian spaces, also called as anthropoid or form spaces. All these spaces are again normal and quite desirable for the establishment of proper molar occlusion as well as for the incisor liability correction. Now, this is a special problem, ugly duckling stage. It was between 8 to 12 years, and commonly, most of the parents are concerned about this particular problem. Usually, around 8, 9, 10, 11 years, they'll be visiting you for a special plan that can this be corrected. But now, once you have the basic knowledge that this is self-correcting malocclusion, it will get corrected once the permanent incisors erupt. Okay. So it is a type of self-correcting malocclusion. You not go for any treatment. This is just an example. You can see that at 9 years of age there was a midline diastema getting corrected on its own once the lateral incisors have erupted and can be erupted. So spaces are gone. The midline has gone, the diastema has gone, the crowding is getting corrected. So it is a self-correcting malocclusion. So it is very common self-correcting malocclusion that one can have a consultation from the parents. Leeway space again is an important concept, especially this is important for molar correction because the lower leeway space will be utilized for mesial migration of lower molar. So it will get into class 1 molar relationship. And if at all there is a premature loss of primary molars, especially the second molars, primary molars, one has to hold the space. There can be chances of correction of anterior crowding using the leeway space also. So one has to be very vigilant about managing the leeway space. Here the role of space maintenance is quite important. So most of the cases wherein we want to preserve the space, obviously the problem comes whenever there is a loss of primary molars. Okay. When should we consider exfoliation to be late?
Participants, please mute yourself. There's a lot of turbulence. Dr. Atasi, please mute yourself.
Okay. So generally, protocol is saying that the deciduous teeth should get exfoliated within about 3 months after exfoliation of the one same tooth in the contralateral arch. Okay. So any delay more than that, we should consider a disturbed schedule of eruption. So what can be the reasons? Many a times, the reason for this could be overretained deciduous teeth, fibrous gingiva, ankylosed deciduous teeth. It is commonly seen in the lower second deciduous molars. Show an example. If you see this OPG, you will observe that all the second deciduous molars are ankylosed. And what has happened with this is you can see the sixth are erupted. So there is obviously a difference in occlusal plane. You can appreciate that all the second deciduous molar are submerged. We call it as a submerged teeth. What will happen with this is obviously the second three molars will not get erupted. They will change its path of eruption. You can appreciate on the right side, the second premolar is going out of its normal path of eruption. So diagnosing a disturbed exfoliation, what is the reason? The commonest reason, as I said, one has to consider the fibrous gingiva, ankylosis, which is quite common as opposed to our thinking that ankylosis is not that common, but what we see in the clinical practice, it is quite common. Especially look out for this in the lower second deciduous molars, it is quite common. There can be overhanging restoration, especially in the distal part of second deciduous molars that can prevent the eruption of the first permanent molars. There can be presence of supernumerary tooth. The commonest supernumerary tooth that we know is a mesiodens. Just remember that mesiodens more often than not is a paired uh, supernumerary tooth. Always look out and always take an IOP, because there are some cases in which there is a mesiodens which is present between the incisors, and second one is also there which is intact. The case that I am showing here is it has a mesiodens which is in an inverted position. It is quite a rare occurrence, but such type of mesiodens can be seen. Obviously, one has to remove these mesiodens as early as possible. Whenever we see these cases, it will be like an emergency. One has to extract these. Okay, but always look for the paired mesiodens. Second is abnormal path of eruption. Now, again, this is the commonest problem that parents visit to the dentist, that saying that the permanent tooth is getting erupted from the lingual side. Okay. Now, one has to look out for the incisor edges of the incisors. Once you see the incisor edges on an incisor coming quite lingually as compared to the deciduous incisor, one can extract the deciduous incisors. There is no harm in that, and it has been said that there will be spontaneous correction of position of lingually erupted permanent incisor almost in 25 to 30% of the cases. So whenever you see erupting incisor, especially in the lower dentition on the lingual side, at least if you see a 1/3 of the tooth, you can extract the deciduous incisors. That is the same deciduous incisor at which position the incisor, permanent incisor, will be coming. So this is a common problem again then one can encounter in the clinical practice. Second is again which is quite common. As I said, there is a chances of distal caries in the second deciduous molars that will prevent the eruption of the first permanent molar. So it will be called as a ectopic eruption of the first permanent molars. The interceptive measure that we employ is quite simple. We can just place an elastic separator between the deciduous second molar and the first permanent molar, or just tie a brass wire between the primary second molar and the first permanent molar. If at all still it is not erupting, one can go for the disking of the distal surface of the second primary molar just to release the first permanent molars. Okay, especially this can occur in the maxilla. It's quite common. So again, one has to look out for ectopic eruption of first permanent molar. So say if a patient comes to you at an age of say 9 years, 8 years, and still the first permanent molars are not erupted, one has to be one has to go for the diagnosis. One has to take the proper X-rays and diagnose the case whether it is a case of a ectopic eruption of the first permanent molars. Another common occurrence is a need for the balancing extraction. Now, balancing extraction is nothing but extracting a same deciduous tooth on the opposite side. Now, if you see that in this figure, on the left side, the deciduous canine has got exfoliated at an early age. What has happened is lower midline has shifted on the same side. So, to compensate that, one can extract the deciduous canine on the other side. This is called as a balancing extraction. There is another term called as a compensating extraction. It is the extraction of the same tooth in the opposing arch. So what is the difference? The difference here is in balancing extraction, opposite side of the same arch, while in the compensating extraction, we extract the same tooth in the opposing arch. Okay, so this is to prevent the to maintain the molar relation. So the two types of extraction that we
just a minute. Participants, please mute yourself. There's a lot of turbulence. Participants, please mute yourself. Dr. Pranjali.
Yes.
Please mute yourself. There is background noise from your side. Please mute yourself. Yeah, so please start.
Thank you. Next is serial extraction. Now, serial extraction has quite a lot of historical importance. There is a lot of literature which is present. Way back in 1929, Jalgren has given this term. Nance called it the planned and progressive extraction. It has defined as it is a planned and sequential removal of certain primary and the permanent teeth to intercept and reduce the dental crowding problems. But we'll see subsequently that why it has faded into a clinical practice. There are certain reasons why it is not practiced that frequently, at least as an orthodontist, we don't do it quite frequently unless there is a specific indication. The rationale behind this concept was if there is an arch-length tooth material discrepancy, one has to go for the serial extraction. The discrepancy should be more than at least 10 millimeters. Physiological tooth movement is there according to the concept. It says that if you plan the deciduous teeth extraction properly, the permanent teeth will have a tendency to go towards the extraction spaces that will reduce the amount of crowding that will be there once they erupt. So that is eruption guidance, what they were talking about. So these were the two rationales behind the concept. The indication basically is any class-on-skeletal relation which arch-length footstep discrepancy of more than 10 millimeters. Okay, so that is the basic indication. One has to have a class-1 skeletal base with discrepancy more than 10 millimeters. Now the problem here is we are not in a position to diagnose properly whether the discrepancy is more than 10 millimeters or not. It's just a guesswork. Sometimes we will get a gross idea from the X-rays. You can get some ideas from the model analysis. But it is very difficult to say that the discrepancy is more than 10 millimeters or less than that. Okay, so you can have just gross guideline here. Contraindication obviously will be a space dentation, whether the crowding is less, teeth which are absent, open bite, deep bite, class 2 and class 2 skeletal cases, left lip and left palate cases. So all these cases definitely we will be having some different treatment plans. So major focus usually in such cases is not related to crowding. Okay, so there are some other problems. Definitely in such cases, the serial extraction is not indicated. So the basic contraindication would be any skeletal class 2 class 3 base with absence of permanent dentition and limited crowding. So that is basically what is the contraindication for serial extraction. Diagnosis, as I said, for any case that we have is like clinical examination, analysis, model analysis, radiographs and photographs. Now, classically, I think everybody knows this. I'm not going to details of this because the sequences, most of the students we have learned this. Davis method was CD4, the Tweeds and Nance method was D4C. So basically, what we are doing is we are extracting deciduous canine first. Okay, this is what is Bevel's method is there. Then we extract deciduous first molars, and once the permanent premolars erupt, first premolars erupt, we extract the first permanent, first premolars. Okay, so this is the normal sequencing of Bevel's method in serial extraction. There is a modification of the technique, especially in the mandible. Since in mandible, usually the canines will erupt before the first premolars, and that is the reason why in mandible one may have to enucleate the first premolars at the same time if you extract the deciduous first molar. Okay, so that is the reason why again here knowing the basic knowledge that in the mandible the canines erupt before the premolars. Okay, so this is a modification of Bevel's technique in mandible. Now these are the certain advantages, but I think science has proved certain advantages. What has been given in the books is not correct. For example, duration of fixed treatment is reduced. It need not be so. There are some cases in which the similar time is required most of the times. It says that results are more stable. Again, science has differed from this. There are some articles in which they say that stability with serial extraction or late treatment is almost the same. Depends upon the what treatment options that you choose. But definitely, it can be physiological treatment. The physiological trauma due to malocclusion is definitely less. Oral hygiene is definitely better because if you reduce the crowding at an early age, the hygiene will always be better. We see just a case. Now, this is an interesting case. I say interesting only because if you see this case, there is already very big diastema. But in this case, we tried serial extraction. You'd say why serial extraction was attempted. If you look at the OPG of this case, what has happened here is the patient got his deciduous second molars extracted somewhere else. And what has happened? The molars, first molars have moved mesially, all the first molars. So there was obviously the linear space has gone. If you see this OPG closely, there in the upper arch, the canine's first premolars and the second premolars are almost bunched out in the same area. So definitely in this case, it will require a lot of space for correcting these malocclusion. And if the serial extraction is not attempted, there is a chance in this case that this case may turn out to be a difficult one. Okay, so what we tried was we started with the serial extraction. Uh, this is just to close the diastema of the fixed brackets with this. This is the condition once the first premolar is extracted. Okay, the anteriors have got aligned with initial C and D extraction. And just see, without any orthodontic treatment, the arches were quite nicely aligned. Now, this just mind you, this is not with any orthodontic treatment. This was just guiding of the dentition. The mild orthodontic treatment that we carried out was just to close the diastema, two brackets in the central incisor. But again, if you see the lateral cephalogram, there is a spacing between the canine and the second premolar. So this is the problem that will occur with any serial extraction protocol. There will always be some spaces which will remain. In this case, fortunately, it was not too much. But there are some cases in which the amount of space is so much that it is very difficult for us to close the remaining spaces. So this cases was turned out to be quite well. It was settled with the places. This was after normal occlusion that was achieved after fixed orthodontic treatment. And this is 10 years after the treatment. The results are quite stable. But I think this is a case in which there was need of a very good clinical acumen, clinical judgment was required. And this is the major disadvantage of serial extractions. If the judgment is not that good, you may land up with a problem with the patients because patients are concerned most of the times that treatment will be reduced, not with need of any second treatment. But if the judgment is not good, ultimately you will end up with a problem with the patient's parents also. They will need a lot of second phase of treatment. Okay, so this is the basic problem with serial extraction. And that is the reason why I think one has to consider any good orthodontist, orthodontist, if at all you want to go with the serial extraction. It is not a part of undergraduate practice. It is very difficult to manage these cases if something goes wrong. But the space regainers. The space regainers are called upon especially when we lose your second deciduous molars at quite an early age. Confed theory suggests that once you extract the second deciduous molars, there is a mesial movement of the first permanent molars. Closing that spaces, there is a loss of arch length. So obviously, in such cases, there is a need of distalization of molars that we call it as a space regainers. Now, in orthodontics, we have a special section of molar distalization. Okay, so that is just to gain the space for the anterior dentition. But here, what we are talking about, gain the mesial movement of the first permanent molar. It could be fixed, it could be removable. This is a Gerber space regainer. It is quite famous regainer in which a band is cemented around the molar, to which a U-shaped tube is soldered, in which a U-shaped wire is placed, and in between there is an open coil. So it is quite a lot of lab work is needed in this, but it is a quite famous space regainer. There can be a modification of that in which we can just place two tubes, Buckley and Nengoli, through which a U-shaped wire is placed and which is in contact with the mesial tooth, especially usually with the first premolar. And we slid a open coil spring over the same wire. So it is a modification of the Gerber space regainer. There are removable space regainers using the jack screws. You can have Japanese appliance, King's appliance. There are many appliances. I think with paucity of time that we have, it's not possible to cover all this. But for anybody who is interested, one can go through these two articles. These are very nice review articles. Space regainers in pediatric dentistry and a similar article, space regainers or review. Both are very recent articles. You can just Google it. You will be getting the full video for these articles. These are two basic articles that one can go through. Each is also regarding the crossbite. Now, crossbite is an interesting problem because it can have its implications dentally as well as skeletally. It could be anterior, it could be posterior. It could involve single teeth, multiple teeth, unilateral, bilateral. Again, it is out of the scope of the presentation, but I'll just guide you through the basic guidelines that you can follow in the practice. Now, crossbite we call it as an orthodontic emergency. Okay, and most of these anterior crossbite cases are the cases in which there are features of developing class 3 malabsorption. The commonest reason for single tooth crossbite usually is lingually erupted maxillary incisors. Posterior crossbite is another problem which is difficult to diagnose because most of the posterior crossbites are because of bilaterally narrow maxilla. Always remember that if you see a unilateral posterior crossbite, the reason usually is not a unilaterally constricted maxilla. It is a bilaterally constricted maxilla that can lead to a unilateral crossbite. We'll see that with an example. The treatment could be, you can start with the tongue blade therapy at a very early stages. You can use Catalan's appliance, you can use composite implants, Z spring, quadhelix appliances. There are many appliances. This is an example of using a tongue blade therapy. Mind you, this will be helpful only at the initial stages of the anterior crossbite development. Once the teeth are erupted, it is not of any use. This is called Catalan's appliance. Now, Catalan's appliance historically was a metallic inclined plane. At a 45-degree angulation was there, but we can make it with acrylic also. This is for the single tooth crossbite. You can see Catalan's appliance was cemented in the lower dentition with a 45 inclined plane, and it got corrected within a space of hardly a month or two. Okay. The problem here is obviously there will not be any occlusion in the posterior dentition. So in such cases, one may need to go for some occlusal support posteriorly. One can build up some posteriors temporarily with GICF composite, so that patient will at least able to chew with such type of appliances. Mind you, these appliances are not to be kept for too long. There can be chances of developing some other problems. So this is for the shorter term treatments. This is a simple appliance with a anterior posteriorly placed jack screw. You can use a simple Z spring. This is a case treated with a simple Z spring, two Z spring behind the upper incisors with the bite blocks to disocclude the occlusion. And it was getting corrected within a period of 3 to 4 months. So it is again a simple measure that you can follow. Posterior crossbites is a special problem. As I said, if you see this figure, what has happened here is the mandible has shifted on the left side, the midline has gone very, the upper midline and lower midlines are not matching. But again, as I said, unilateral crossbite doesn't always mean it is just a maxilla constricted on one side. It is patient by habit try to upload on one side and ultimately will take the mandible on the other side. So there will be shift of the midline. There will be unilateral crossbite. So the reason usually is a bilaterally constricted maxilla. So always consider in 99% of the cases expanding the maxilla in both sides. There are some expansion screws which are available, unilateral expansion screws. But in practice, clinically, I have seen that those are of very limited cases. Most cases will require the bilateral expansion. We have a lot of expansion appliances. We have slow, rapid. Again, I'm not going to details. It is topic of 2-3 lectures actually, but one has to consider at an early age, one can go for the simple stool expansion appliances. You can go for the removable expansion plates with the jack screws, coffin spring, or if the patient compliance is not very good, one can go for the acquired helix. Beautiful expanders which are present nowadays are NITA expanders. Transpose was an excellent expander appliance, but I think is not available in India nowadays. But if you got any chance, you can try this in your practice in the PG department also. It is very nice slow expansion appliance. And just share a case. Okay, so this was a case treated with a simple jack screw appliance. You can see there is a unilateral crossbite on the right side, and the crossbite is also there. A simple expansion appliance was given with the jack screw. It was opened with a bite block, obviously to disocclude the dentition. The crossbite got corrected quite beautifully. Again, no fixed orthodontic treatment was done in this case. Almost all the correction was achieved with a single expansion appliance. Again, obviously, one needs to have a lot of compliance from the patient also. Not say that with the removable appliances, we need to have this compliance from the patients also. Rapid expansion, there are many types of screws which are available nowadays, Haas, Hyrex, Mine expander, Isaacson expander. There are n number of expanders which are available. One can choose anyone he or she is comfortable with. This is a case in which there is a total crossbite of the maxilla. Now this was because it was just at the beginning of the mixed dentition, a simple expander was placed. This is a harsh type of expander, rapid expander. It was opened, and if you see this case, almost all the crossbite was corrected except the right lateral incisor. It still was in a crossbite. So it was finished with the fixed appliances. The occlusion is quite nice at the end of the fixed orthodontic treatment. But what I'm trying to stress here is uh, diagnosing a case and putting a proper expander, if required at an early age, has its role, because in this case, if we're not given any expander appliance at an early age, just imagine what will be the long-term skeletal problem in this patient. Because we had given at an early age, the treatment was quite simple in the second phase. Regarding the habits, again, habits is a part of preventive orthodontics, I think, but there is some overlapping. There are some habits which we need to intercept at certain ages, like bruxism. Now, bruxism is a problem which not that often is seen in the children, but nowadays with a lot of online training and children at home, this is increasing nowadays. So, bruxism in children is also increasing nowadays. Unfortunately, as a dentist, as an orthodontist, periodontist, we don't have that much appliance therapies for these cases. One can try simple tomes appliance, like this is a commercially available appliance which is marketed by company from Bangalore. You can have a parent and child counseling. Now, this has important role because most of the bruxism cases has some underlying nervous tension or stress related issues. So here the role of dentist, periodontist, orthodontist comes regarding the counseling of the patients. Digital sucking is a special problem. Almost all of us are well aware about the digital sucking, but clinically we consider it to be normal till the age of 4 to 5 years. Now, till 4 to 5 years, we don't advise any active treatment. We can just counsel the parents, we can just counsel the children. Usually it diminishes gradually, but if it increases in frequency and duration, that is a problem. And more often than not, parents come to you like this, that we have tried everything, we have tried to put everything and touch it, everything, but the child is not stopping the habit. Then one can go for a reminder appliances. But just understand this is the appliances that we give, that is the reminder appliances using rakes, grids, spikes, all those are there. But these are all reminder appliances. These will only work if at all the child is ready to stop the habit. So one has to take the child into consideration. You should counsel children also that he or she, if he or she is ready to stop the habit, then only these appliances will work. So as opposed to what we call it as a habit breaking appliances, these are not habit breaking appliances. These are habit reminder appliances with which if patient is ready, he or she will stop the habit. A classical example is a blue glass appliance. I think given the Haskell's appliance also it is called as. Tongue thrusting habit is another problem which has some dilemma in the literature also. We don't know exactly whether the tongue thrusting is primary or secondary, but science has proved that tongue thrusting usually is secondary. Secondary means there is some initial malocclusion that develops, like for example in a thumb sucking patient. Because of continuous placement of the tongue, there is creation of an open bite, which ultimately will lead to tongue thrusting. So it is quite common as compared to a primary tongue thrusting, meaning there is a retained infantile swallow. If you see any newborn, he or she swallows with tongue interposed between the gum pads of the upper and lower dentition. That is called as infantile swallow. If it is retained over a period of time, it will lead to a primary tongue thrusting. But mind you, this is quite uncommon. Okay. So most common tongue thrusting is secondary tongue thrusting. Again, we can go for the reminder appliances similar to the thumb sucking habits, or if you can diagnose the case at an early age, these two functional treatments are quite useful. Given by Andrews, ask the patient to practice the normal swallow, that is putting your tongue behind your upper incisor and swallow 20 times, 3 times a day, or you can just put a sugarless mint and hold it against the incisive papilla till it melts and then swallow the saliva. This will help in developing a normal tongue posture in the children. So these are the appliance reminders again for a tongue thrusting appliance. Next is the mouth breathing appliance. isn't a problem, mouth breathing habit. It is a problem which is most often than not is related to some anatomical reasons. That is, deviated nasal septums, tonsils, adenoids, which are quite common. And if you see any mouth breather patient, okay, what we call it as an adenoid phase. Okay, this is quite common, and in the literature, this has been explained quite nicely. It is called as an adenoid phase. Typical phase, long, narrow phase with open mouth posture, drooping eyelids. Okay, a sleepy face. This is all the features of mouth breathing patients. Mind you, the clinical tip I want to give you here is always, if the child comes at the age of 8, 9, 10, 11, 12 years of a mouth breathing condition, definitely take an ENT evaluation, because most of these cases will have enlarged adenoids, that is a pharyngeal tonsil, blocked nose, and if at all you don't remove the cause, ultimately your correction of mouth breathing will not be possible. As a dentist, we have very limited options. Oral skin was once used, but it is not that much used nowadays. We can have the pre-orthodontic trainers with holes; those can be given. But the treatment of mouth breathing habit is basically related to correcting the underlying cause. Okay, so that is where one has to focus in treating these cases. Lastly, the interception of developing malocclusion. Uh, we have class 2, class 3, class 2 div 1, class 2 div 2. And usually, all these skeletal malocclusion will need some comprehensive treatment in the second phase also, once the permanent dentition erupts. But the role of pedodontists, orthodontists at an early age, interceptive measures also plays a role. I think in the next lecture, Madam will be covering the functional appliances. So I'm not going to details about these developing malocclusion, but just remember that these three malocclusion, that is class 1, 2, 3, can occur in different types of patterns. Class 2 and class 3 specifically, one needs to focus on the phase 1 correction, that is skeletal correction at an early age. Dental correction can wait. Okay, so in such cases, if you observe there is a skeletal problem, always focus on the jaws. Don't focus on the dentition per se, only because you can correct it with disease at any period of time afterwards. Most of the patients of class 3, mild to moderate to severe cases, may turn up into a surgical phase case, that is a stage phase case, that is a surgical case, because in class 3 cases, as we know, it is very difficult to correct the underlying skeletal problems most of the times. So class 2 is more amenable to the orthodontic or the orthodontic treatments, while class 3 is not that amenable, but still, as the mantra says, catch them young, try to treat them as early as possible. So at least you can reduce the severity of the future. So to conclude, as I said at the start, one should encourage the parents to visit the dentist for their children at the age of 6 to 7 years, just for the screening purpose. Have your basic knowledge thorough. Okay, if you have this knowledge at your disposal, at the first visit only you can observe the problems that the parents will not be able to understand also. So one has to be very vigilant about understanding the basic concepts, identify the self-correcting and non-self-correcting malocclusion at this stage, and ultimately it is an interdisciplinary care. I think the term interceptive and preventive orthodontics is slightly misleading. It should be called as a preventive and interceptive measures, or dental measures overall, because there is a role of dentist, periodontist, orthodontist, and restorative dentist also. So I would call it as an interceptive dental measures that one has to look for in the development of the children. So thank you for the patient listening, and this is my email and mobile number. I practice at Aurangabad, so anybody who has some queries, you can just mail me, you can just WhatsApp me. If have any chance to meet up in my practice also, everybody is most welcome. So thank you for the patient listening. Thank you organizers. Again, thank you Department of Pediatric Dentistry, MIDS Dental College. So thank you. Let's go.
Thank you, Dr. Umal sir, for such a wonderful and informative session. Now I open this session for question and answers from the participants. We have a few questions through chat box, sir. I would just share the question with you. There is a question by Dr. Swapnil Yadav. He's asking about what are your personal experience and views on serial extractions?
Okay. So, as I said in my presentation also, I am not too much inclined towards serial extraction. The only reason is it is very difficult to diagnose a case unless you have a frank arch-length tooth size discrepancy. Obviously, it helps, but convincing the parents to extract the teeth at a certain early age, that too at the age of 8 to 9 to 10 years, and giving them the guarantee that long-term treatment will not be required is I think is problematic for us only. So my experience, I again have landed with a case in which I needed to treat the case longer than what we normally do in the orthodontic practice in the second phase also. So unless I'm very sure that patient will land up with a severe crowding and patient is known to you, patient is understandable. Again, the parents need to be understandable about the problem. If the parents are concerned, if you explain that, if they can understand the problem, then definitely you can go for the serial extraction. But educating them and understanding from the parent side is also sometimes difficult. So I would suggest to go for this special treatment in interceptive orthodontics with caution. Um, if you are in doubt, always consult a specialist. Always consult the parents first because their concern is again has to be taken into consideration. So I hope this has answered your question.
Yeah. I would request other participants also. You can unmute yourself and ask questions directly to Dr. Umal sir. But please do it one by one. Any questions from any participant? Okay. I feel the questions are over from this session, sir. Now I request Dr. Veena Areli to take upon the session. I would have a brief introduction about Dr. Veena. Dr. Veena Areli is an alumni of Bapu's Dental College and Hospital, Davangere, and she has completed her post-graduation in 2009. She has secured 7th rank in university exam and she is practicing exclusive pediatric dentistry in Bangalore. Her interests are in the field of conscious sedation, pediatric obstructive sleep apnea, and management of children with special healthcare needs. She believes in the concept of catch them young and watch them grow in her mantra for treating the developing malocclusion in growing children. Dr. Veena is presently working as professor and head of the department at GSL Dental College and Hospital at Rajahmundry, Andhra Pradesh. And she will be speaking about myofunctional appliances to correct the malocclusions in developing dentitions. Over to Dr. Veena. Veena ma'am, please start your presentation.
Very good morning to all of you. Prasanna, am I audible?
Yes, ma'am. Yes.
Yeah. Is my screen visible, Prasanna?
Yes, ma'am. It's visible.
Yeah. Yeah. A very good morning to one and all. First of all, thank you, Dr. Yogesh Kali sir and Dr. Prasanna Dahake and all the faculty and the principal of MITDSR for considering and giving this opportunity. Warm welcome from the Department of Pediatric and Preventive Dentistry, GSL Dental College and Hospital, Rajahmundry, Andhra Pradesh. I think Dr. Umal Joshi sir highlighted a lot of interceptive procedures, when it comes to treating developing malocclusions in children. But whatever sir discussed were mostly with respect to the dentition per se as well. We know where there are dental malocclusions. We are not it's more of dental rather than skeletal. But when we want to consider, there could be some cases where we see children coming to us at an early age, because we as a pediatric dentist are the ones who are going to see the children at a very, very early age. Probably it could be because of dental caries or some other reasons. And most of the times we see that there is something wrong with the developing teeth or with the profile of the child. And sometimes we are so confused, we don't know what to do. The old myth still stands good for most of us, that let's wait till 13 years and then let's see what to do. But now the field of orthodontics is also changing, and there's a lot of shift towards airway orthodontics. So we need to understand where we stand today as pediatric dentists in treating these malocclusions. So whenever it comes to, seeing these children with a developing malocclusions, I call it like a game of a chess. We are always playing against the nature. The nature is always making some moves in the development of the child, and we do not know how that particular child is going to grow. If we do not analyze that particular move or that particular growth at the right time and play skillfully, then probably we might lose the game. That is what happens, because a child coming to us at 6 years, we see there is a malocclusion, we try and tell the parents that this could be the reason, but then again, prevention and interception, as I've seen in India, takes a backseat. Parents still have that myth that correcting of malocclusions is at 13 years. When we try to say that there could be something that we could do at an early stage, they always take a backseat. And the same child, they come back to us at 2 years later saying that you said this at that time, is there anything that we could do now? But unfortunately, we would have missed the time. So whenever we talk about myofunctional appliances or intercepting a developing malocclusion, time and growth and development of a child is very, very crucial. So we need to understand that. And Mark Cruz, way back in 1900s, only said that bone sets the tone, but it is the tissue which is the issue. So all of these orthodontists who practiced way back and they introduced myofunctional orthodontics always knew that it is not just the bone, but it is the surrounding soft tissues, the muscles, which are playing a major role in the development of the bone. And when we understand that, probably the war will be over, where we can find room for all the teeth if we start early enough and try to mimic what the nature has intended us. There is a certain way that the nature wants us to grow, but because of the environmental factors, because of the epigenetic factors, like it could be a habit, it could be early dental caries or early childhood caries, where there is loss of tooth structure, loss of arch material, arch length, where the malocclusions tend to happen. So if we look at the malocclusion per se, where we know that it is the role of both genetic as well as the epigenetic factors. So what happens is these keep on accumulating, as a result of which there could be an aggravation in the malocclusions. At the same time, whenever this malocclusion is happening and when these the genetic and epigenetic factors are playing a role, there is some compensation also trying to happen. Like say, for example, if a child is developing a proclined upper anteriors, the compensation, what is happening, the lower anteriors also tended to procline forward in order to establish that overjet and overbite. Every malocclusion that happens, every change that happens in the oral cavity, there is always a compensation that is happening. When this compensation happens, there could be a camouflage of the various factors, which could lead to very invasive procedures. So the paradigm shift is that we need to know, initially we always used to learn only about the growth and development. It was always about the growth and development, but now the paradigm shift is we also need to understand that there is an adaptation that the oral cavity is undergoing every time the child grows, every time the tooth is developing there. So malocclusion is one solution for the complex adaptive orofacial system to be in equilibrium. So malocclusion is just a symptom. It is not, we cannot, or we can call it as a sign for the various adaptations that is happening in the orofacial system. So for example, if a tongue is placed at a lower level, what happens? The maxilla might get constricted. Yeah, the mandible crowding might be there. there could be posterior crossbites. Now what is happening? The oral cavity is trying to adapt itself to this lowered tongue, the posture of the tongue. So how can we correct this? Probably if we are able to correct the posture of the tongue, probably we could get in alignment with the nature and bring about the equilibrium there. So that is what we need to understand. So this is the common, controversy. What came first? Is it the egg or is it the chicken? And every time just few people might say it is the egg, few people might say it is the chicken. Now this holds good even for the oral cavity. There is always a controversy with respect to what is first, what determines what. That is it the function or is it the form of the oral cavity? There is always a controversy that few people or one school of thought says that it is always the function which plays a role in determining the form, but another form of school says that it is the form which determines the function. Well, I believe it's either ways. When functions are not done in the way it needs to be done, it definitely is going to determine the form. Slight changes in the form can also determine the function. So identifying the function as well as the form is a key in proper diagnosis and early management of malocclusions. So any change in the morphology of the orofacial system could lead to change in the functions. And this was very well explained by the functional matrix theory that was given by the Moss. What he said was the function that determines the form is mainly three functions of the oral cavity. That is your respiration, the mastication, the swallowing. If these three functions are in place, that is the way they are intended to do, if we do it, then probably there is no change or malocclusions that are going to develop with respect to the orofacial system. Like let's give a small example, respiration. How are we all supposed to respire? It is basically through the nose. Why nose? Because when air enters into the nose, it is basically purified. We breathe the purified air. Okay, so because of that, the upper respiratory tract infections are very, very low. Okay, and when we breathe through the nose, the air that enters through the nose acts as a positive matrix for the nasal floor to develop, as well as for the palatal shelves, also the palate to take its proper shape. And when you're breathing through the nose, what happens? The tongue is always held against the palate, because of which the palate is also widening. There is no high arched palate. But on the contrary, if a child is mouth breathing, what happens? If you ask a history of to a mother or to a parent whose child is breathing through the mouth, they always give a history of allergies. They always give a history of frequent cold and cough. They give histories of upper respiratory tract infections. Along with that, you always see that there is an open mouth posture, the tongue is placed low, high arch palate, maxillary constrictions. Everything in that particular child is compensated. So we need to understand that whenever we try to intervene a developing malocclusion in children, specifically skeletal with respect to using the myofunctional appliances, we need to understand whether the function is maintained properly or not, and whether the appliances that we are going to give are trying to bring back that particular function back to normal. So any new pattern of function, any change in the pattern of function, there is definitely going to be a new morphologic pattern. And that is why an oral tripod was established, where they said that the morphology, the posture of an individual, and the function are interrelated. Any change with either one of these is going to bring about the changes in other two components. Very, very important to understand this, because based on this, there is a new branch of dentistry which is coming. His body is not straight but forwardly placed. Any child with a class 3 malocclusions are usually with a concave profile are going to have the posture. If you look at the child from a lateral view, the whole posture, he will be sliding backwards. So any change that occurs, so that is why now a lot of importance is being given to the malocclusions. And if you look at the most popular theory, that is the equilibrium theory, this was one of the articles published way back, where they revisited the various factors influencing the position of the teeth. And one of the findings of this particular article, what is stated was, it is always the pressures from either the musculature which plays a role in maintaining the teeth in equilibrium, that is in the neutral zone. your teeth in equilibrium are maintained because of the lip, the musculature that is present in the lip, the buccinator, the perioral musculature, that is the orbicularis oris from the outside, and you have one major muscle to, oppose these three musculatures, that is your tongue. So you can imagine the tongue is a very strong muscle which can influence the development of the teeth and place your teeth in an equilibrium zone. If you look at this, okay, if you look at this picture, you see that the lip is exerting a force of around 20 pound, 20 psi, whereas the tongue is applying around 50 psi. Along with the lip, there is also the buccinator muscle. So, but the tongue is a very strong one. So that is why a simple habit like a tongue thrust can cause a severe malocclusion like open bite. And like I said, the posture of the tongue is very, very important. Every time you swallow, one of the functions that Marx stated was the swallowing. Whenever we do swallowing, the tip of the tongue is always placed against the incisive papilla, and then we swallow in case of mature swallow. But what if it is a retained infantile swallow? Why that particular teeth are moving forward is we tend to swallow around 700 to 800 times in a day. And every time your tongue is swallowing in an abnormal posture, it is exerting a huge amount of force, which was somewhere around 500 to 600 grams every time we swallow. So imagine the amount of force that you're exerting throughout the day. Yeah, that could definitely lead to a malocclusion. So it is very important that with the correction in the developing malocclusions using any myofunctional appliances, we need to see that this harmony is maintained between the tongue as well as the lip as well as the buccinator muscles. So any discrepancies again are going to lead to malocclusions. So another important function of the tongue, like I discussed, is with respect to its posture, is that one of the main functions of the tongue is in sutural activation. Okay, the tongue, when the child is having a breastfeeding, or the child is we are having a normal swallowing position or in a postureless position, the tongue we see is always placed against the palate. During the developmental years, if the tongue is placed against the palate, it is known to cause the activation of these three sutures, because of which we get a proper horseshoe shaped or a U-shaped maxillary arch, where we can develop, all the teeth can develop in its original place without causing any malocclusions. So that is why we say breastfeeding for the first 6 months or 1 year is very, very crucial, because it is not just the nutrition part, but it is also the development of the orofacial structures that are detrimental if the child is being switched from breastfeeding to bottle feeding at a very, very early stages. So the tongue teeth complex applies pressures on the incisive sutures, it applies pressures on the mid-palatal suture as well as on the transverse palatal sutures, and leads to the development of the palate. So very important aspect when we need to consider that, especially evaluating the developing malocclusions in children, is with respect to the tongue posture as well. So like I said, every compensation that happens in the oral cavity has a competence, and there is always a compromise. Now, if you look at that, what is the competency we are expected? The nasal breathing. When we do the nasal breathing, we need to achieve a tight lip seal. The tongue should be on the palate. There should be a wide space for the tongue to exert its motions, efficient chewing and swallowing. But whenever this competency is compromised, what happens? There is always a compensation that is happening. Child is not able to breathe through the nose. The child starts breathing through the mouth. The child is not able to maintain a lip seal. The lip competency is not there. We always see the hyperactive mentalis there. The tongue is not placed on the palate, hyperactive buccinators, because there is no resistance for the buccinators when it is applying the pressures. Tongue is not having a wide range of motion, that is the arch space is decreased, then there could be a low tongue posture. So whenever this compensation is happening, there is always a compromise that the child is undergoing in terms of jaw retrusions, that is the jaws are not growing properly, or the jaws are growing uninhibited. There could be crowded incisors, narrow dental arches, maxillary dystrophies, proclinations, retrusions. Every possible malocclusion will have a competency and a compensation. So every time you try to choose, an appliance, or you want to intervene a child for a developing malocclusion, you need to do a functional analysis. Functional analysis involves the identifying the postural rest position of the mandible, identifying the tongue posture. Identify does not mean ask the patient to sit and you start observing the child. When the child become conscious or the patients become conscious, they might not perform the kind of functions that are intended to do. As and when the child walks into your dental operatory, or you sit and try and establish your rapport with the child on the dental chair, try and see how he is, how his mandible is moving, how his tongue is moving when he swallows. Is there any change in the musculature in and around the oral cavity that is happening? Very important, we need to have that eagle's eye to identify and these small signs that the child might give when we are talking to the child. So examination of the functional status of the lips, cheeks, and the tongue is very, very important when we need to assess the child for myofunctional appliances in particular. Of course, we normally see these kind of malocclusions day to day in our daily life, right? We might see a child with a retruded mandible or open mouth posture. We see that, like Sir discussed, there could be unilateral cross bites, posterior cross bites, which might lead, bilaterally, the maxilla might be constricted. Or there could be an the overjet might be very high, the overbite might be very, there might be deep bite. So what is it that we can do? Is there a solution that we can? Of course, this is all there in our textbooks. We have all read this, but when it comes to practice, we as pediatric dentists take a backseat because we I feel we need to highlight more on this during our post-graduation training program. So the key to giving or diagnosing or intervening such malocclusions depends upon your diagnosis, a proper patient selection, because anything that goes wrong in a patient selection might worsen the case. It might, rather than reducing the severity, as well as a proper treatment planning. And when it comes to myofunctional orthodontics or interceptive orthodontics, like Dr. Umal Joshi sir was highlighting, it comes in different phases. The phase 1 might be intervention with a myofunctional. Intervening with a myofunctional does not 100% guarantee you that fixed orthodontic therapy might not be required. There could be, because myofunctional appliances do not bring about individual tooth movements. Please bear that in mind. So what happens is you need to identify the cases, or you need to understand and make the parents also understand that by myofunctional, you are trying to deal with the jaws or the skeleton per se, but the individual tooth movements would definitely require the use of fixed functional therapies, which could be at a later date. This is very, very important to understand. And when it comes to diagnosis, what is important is the first and the foremost is the photographic analysis, the functional analysis, model analysis, and radiographic analysis. All these 4 are going to play a major role in your diagnosis. Of course, each one is a 1-hour lecture per se, which we are not going to deal in detail. Most of you would already know it, why photographic analysis is important. Patient comes, you take the photographs, or you see a patient goes off. Later on, when you want to sit and analyze what exactly did the patient look like, or when there was swallowing, was there a hyperactive mentalis? Was there a orange peel appearance, or was there a tongue thrusting? That is when you're, or where all the teeth seen, did the child have a gummy smile, which is an indication of, again, a maxillary proclination, the maxillary jaw protrusion. So for all that reasons, you need the photographic analysis. Of course, model and radiographic analysis plays a very, very important role. When it comes to analysis, again, lateral stuff is very, very important. I personally follow the modified Sassoni's analysis, which gives me a clear indication that which particular jaw is not grown properly. Is it the maxilla? Is it the mandible? Is it both? Is it in excess? Is it in deficient? And how much is it excess and how much is in deficient? Based upon which I can always, I always plan my functional appliances. Now, coming to the topic per se for today, the myofunctional appliances, we all know most of these appliances, we cannot alter the maxilla. Okay, the maxilla is fixed and held by many different bones. So we cannot move the maxilla, but the one particular jaw that we have, or the bone that we have that is movable, is your mandible. And anything that you can do with the mandible at a very, very early stage will help in correcting the developing skeletal malocclusions. When we talk of myofunctional, it is more often we're talking of skeletal malocclusions. And when I was talking about diagnosis, one more important thing that you need to understand is the visual treatment objective, that is the VTO. Anytime you bring the mandible forward, say there is a patient with a class 2 division 1 malocclusion, you see that there is proclined anteriors. Okay, you did an analysis and you found that it was not the maxilla or the teeth that were forwardly placed, but it was the mandible that was retruded, and you want to bring the mandible forward. And when you bring the mandible forward, you always need to see the change in the profile from a retruded mandible. If it is proclined, is there any change in the appearance of that particular patient? If that is so, that is when we call it as a positive VTO. If there is a negative VTO, like there is a tendency for a child to develop a class 3, but still you feel that the mandible is retruded and you try to bring the mandible forward and you feel that the child is going into a concave profile, that is, it is not bring the profile is getting worsened, then it is a negative VTO. Then you will not be able to use most of these myofunctional appliances. So that is one very important aspect that will also help and motivating the parents. Whenever you do that in front of the parents and show them how the profile changes from a retruded mandible when it is brought forward, how the profile is changing, then most of the parents would also be motivated to undergo this particular appliance therapy. So what are the major treatment principles when we talk about myofunctional appliances? Either it is these particular appliances, you take anything, whether it is Frankel, whether it is twin block, whether it is an activator, bionator, anything, they either act by eliminating the forces, or they act by application of forces in some cases. They also help in, because the forces are eliminated from the surrounding musculature, this could lead to eruption of the teeth in the proper sequence and in the proper place. They also bring about a balance in the linguofacial muscles. When it is linguofacial, that is between the tongue and your orofacial musculature. And also they help in the mandibular repositioning. So if you look at the actions of MFA, they might bring about the orthopedic changes in the form of, whenever the mandible is brought forward, what happens? There is a lacunae or a space that is created behind the condyle, where condyle is a secondary cartilage. You might help in the accelerated growth of the condyle, and because of which there could be a change in the direction of the jaws. There could be dental-alveolar changes, which can be brought about in all the 3 dimensions, that is your sagittal, vertical, and transverse. Because your forces are eliminated, it could lead to expansion of the dental arches, and also the tonicity of the muscles could be improved. So a study conducted stated that the orthopedic effects that are brought about by these myofunctional appliances are 30 to 40%, where there is growth, the condylar growth is increased, the condylar remodeling takes place, the glenoid fossa remodeling takes place, so that the condyle does not go back to its original position back again, and because of which there could be an increase in the lower facial height also, because the mandible is brought downward and forward. So that is why most of these myofunctional appliances are not indicated in cases where the child is already a vertical grower, where the lower facial height is already more. Child is vertically growing, we do not indicate the myofunctional appliances, because it further worsens the facial height. Whereas the dento-alveolar effects were seen to be around 60 to 70%. So by giving a myofunctional appliance indirectly, we are trying to bring about the dento-alveolar changes, where the downward and forward eruption of the maxillary teeth were inhibited. We can bring about the retroclination of the upper incisors at a very early stage, and the proclination of the lower incisors could also be seen. Now, these were the various studies which were done way back in, if you look at these studies, they're all done in 60s and 70s, where they show that any 1 mm displacement of the condyle or the mandible anteriorly could bring about could stretch the retractor muscle, that is your lateral pterygoid, the medial pterygoid, the masseter muscles, and when it is stretched, the amount of force that is exerted by these muscles is approximately 100 grams. So imagine if you have to bring your mandible by around 5 millimeters. So imagine the kind of force these muscles are going to exhibit on the surrounding bone to bring about the changes. So the objective of the functional appliance is to displace the lower jaw downwards and forwards, to increase the intermaxillary space in the anterior posterior as well as the vertical dimensions, and also to encourage adaptive skeletal growth. So when you bring about the mandible forward, there is an adaptation that is happening with respect to the muscles, and we do not want that to go back. So by maintaining that, we are trying to bring about the adaptive skeletal growth also, so that the changes that occur to this functional stimulus are maintained for a particular amount of time. the study done by McNamara, they found that whenever there is a functional protrusion that is brought about by these functional appliances, they found there was a change in the sensory stimuli of the musculature. The stimulus was sent to the CNS, and because of which the activity of the craniofacial muscles was changed, and this brought about the forward displacement of the mandible. Along with this, there was also the condylar growth that happened, and the normal structure and function were attained. Now, this difference, whenever you give an appliance, with and without an appliance, was done by a study by Bilal, and he stated that whenever you give a functional appliance in that age group where the growth spurt is maximum, for girls it could be around 8 to 10 years, and for boys it could be around 12 to 13 years. Whenever we give that in that particular age group, now if you see the dotted line, that is the expected growth that happens without any treatment. Okay, it might not reach 100%, it might be a little less. But when we give a functional appliance by identifying the deficient growth at a very early stage or during the pubertal growth spurts, what happens? We can achieve that growth that would have occurred. If the growth would have been normal, then it would have been a true stimulation. The growth would have been 100% or more than 100%. So by intervening at a very early stage during the pubertal growth spurts or the active growth spurt time, we can achieve that particular growth to 100%. So that is why interception, the diagnosis and detection at a very early stage is very, very important. Not going deep into the classification, we all know that they're classified as tooth borne, tooth supported, tissue supported. They could be active, passive. They are removable and fixed appliances, but most of the myofunctional appliances like the activators, bionators, or the frankles, most of them are removable appliances. Okay, now we have the fixed functional appliances also, which are not in purview of a pediatric dentist. Of course, we can always concentrate on the removable appliances. Now, when we look at the advantages of myofunctional appliances, the most important advantage is it eliminates the abnormal perioral muscular forces. It can be started in a very early mixed or in the late mixed dentition stage as well. Most important thing, because they are removable, they are not fixed, unlike the braces or the fixed functional appliances where oral hygiene could be a problem, decalcification of the enamel could be a problem. So oral hygiene maintenance is very, very easy. And most of these appliances are worn at a night time, when the child is sleeping. And why at nighttime? Because the growth hormone is secreted at the nighttime, and most of the growth happens during the nighttime. That is why most of these appliances are worn at the nighttime for a minimum period of 10 to 12 years, and no side effects, like I said, because of mechanotherapy. Of course, it has its own disadvantages because most of them are removable and they are huge appliances. They have many components. They have acrylic components, they have wire components. The appliance per se looks very, very big. So patient compliance might be a problem. So motivation of both the patient and the parent is very, very important. Identification of the growth spurt is a very crucial role when you want to plan a myofunctional appliance. If you are doing anything beyond the growth spurt, you might not experience the same kind of changes that you might when you're giving it in a growth spurt. And it cannot be used in adults. Individual tooth movements cannot be achieved. That is why I said it goes in phases, where the phase 2 fixed mechanotherapy might still be required to bring about those minute tooth movements. And of course, because the muscles do not just adapt within a month, right? It takes its own time to adapt to the new morphology and the new function as well. So it is a long-term treatment, because phase 1, the myofunctional treatment itself could last for 6 months or 9 months. And then later on, there is a fixed mechanotherapy that could again last for a year. So the treatment time could be long, which you should always inform your patients before you start with a myofunctional. Just because you got a case and you have learned something new, don't jump to doing the cases all at a time. You need to take all these things into consideration and an informed consent by the patient as well, by the parent, because patients are minors, that this particular thing would be done. Okay, and at any point of time, there could be some changes that would be required. I would be highlighting mostly on twin block functional appliance, because this is one of the appliances that is very, very easy and which we as pediatric dentists can master, because most of the times we see that class 2 div 1 malocclusions, most of the times it is because of the mandibular retrusion or mandibular deficiencies. Okay, one of the easiest appliances that you can use in your day-to-day practice, you can see the visible changes, as and when the patient is wearing. Duration of time is between 6 to 9 months only. The patients can see the changes within a period of 2 to 4 weeks, right? So because of all these, I feel twin block is one of the very good appliances that we can wear. Whenever you see a patient like this coming to you with crowding, there is a lot of crowding, there is maxillary constriction, there is mandibular retrusion. The question arises for whether do we need to wait for orthodontic treatment or the orthopedic treatment. Of course, like I said, with your diagnosis, with your facial analysis, everything, you need to understand that what is required for that particular patient. Okay. Now, if we look at the occlusion of our teeth, okay, we all know that our teeth are inclined at the inclines, right? We have a mesial inclination, we have a distal inclination, and the teeth are intercuspation. The intercuspation that happens is against these inclines. Okay, so that is a fundamental mechanism of the natural dentition. And these cuspal inclined planes play an important role in determining the relationship of the teeth as they erupt into occlusion. We normally do not see an edge-to-edge bite, right? Even though the molar is erupting in an edge-to-edge relationship, over a period of time, it moves forward and tries to establish that inclinal intercuspation again. So these twin block appliances are nothing but simple bite blocks that are designed for full-time wear, and they achieve this functional correction of malocclusion, where the mandible is brought forward by the transmission of favorable occlusal forces to the occlusal inclined planes that cover the posterior teeth. Now, what these inclined planes are supposed to do, these inclined planes that we give in case of the twin block are known to act as a proprioceptive or a proprioceptive stimulus. Okay. Now, a functional equilibrium is established under neurological control in response to repetitive tactile stimulus. Whenever the child is biting, if that inclined plane intercuspation is not there, there is always acts as a tactile stimulus, and there is a feedback mechanism. The stimulus is going to the brain. Okay, that something is wrong. The teeth are not in a proper inclination, or the teeth are not in proper occlusion. So the occlusal forces that are transmitted through the dentition provide this constant proprioceptive stimulus to influence the rate of growth as well as the trabecular structure of the supporting bone. So it is very important that we establish that particular. So say, for example, a child is in a class 2 division 1, or a molar relation is class 2. What's happening? Your permanent molar is ahead and the mandibular first molar is behind, right? That's how it's a class 2. So what happened? That particular inclines, the mesial and the distal inclines of the cusps are not in proper intercuspation. So every time the patient is biting, the occlusal forces are acting as a proprioceptive stimulus, because of which it might inhibit the growth of the mandible as well. So this proprioceptive sensory feedback mechanism controls the muscular activity also, and it might act as a functional stimulus, and it might inhibit the full expression of mandibular growth. So these unfavorable cuspal contacts, preferably in case of a class 2 molar relations or a class 2 malocclusions, they represent an obstruction to the normal forward mandibular translation and function, because of which the mandible fails to achieve its optimum genetic growth potential. So by altering the position of the teeth, so whenever we give the blocks, the posterior bite blocks, in case of a twin block, what is it trying to do? It is trying to establish that particular inclination back to normal, so that the occlusal forces are transmitted the way it needs to be transmitted. So that is why if you see at the bite blocks, they are placed at an angulation of 70 degrees. That is how our the tooth inclines are also there. So they're placed at 70 degrees posteriorly, because the occlusal forces are supposed to be transmitted in that way. So the study that was done initially by Harvard, they demonstrated the tissue changes that occur as a result of altered function, because of which the mandible is postured downward and forward, and a vacuum is not created, created distal to the condyle. And whenever the mandible is brought forward, okay, the condyle, what you see in the condyle is there is an intense cellular activity, which we call as a tension zone, which is later on proliferated by connective tissue cells, which leads to the and capillary blood vessels whenever the mandible functions in a protrusive position. And this tension zone over a period of time is replaced by bone. The remodeling of the bone happens. Now, whenever you give a twin block to a child and ask the patient to, bring the mandible forward and bite, and every time the space is creating, the masseter muscle tries to readapt itself and remodel itself. And that is when we see what is called as a pterygoid response. Now, this pterygoid response happens within a period of 2 to 4 weeks. Okay. What is this pterygoid response? The child, when every time he's bringing his mandible forward and, biting, this particular readaptation or remodeling of the masseter fibers, and the mesial pterygoid and the lateral pterygoid muscles, what happens is the child will not be able to take the mandible back again. That is, a remodeling has already started. That we call it as a pterygoid response. How do you identify this? You always see that there is a posterior open bite. We achieve that posterior open bite, which is constant. It is not going to go back. The child will not be able to move the mandible backward. That we call as a pterygoid response. And if we achieve this pterygoid response within a period of 2 to 4 weeks, that means the patient is wearing the twin block correctly and appropriately for the required time. If the child is not wearing it, like say we say 10 to 12 hours, the child is not wearing for that particular period of time, we will not achieve this pterygoid response at all. So failure to achieve this pterygoid response means there is some problem with the wearing of the appliance. The child is not following the instructions properly. So the goal with the twin block is to maximize the growth response. We need to modify the occlusal inclined plane to promote a protrusive mandibular function for corrections of skeletal class 2 malocclusions, and take full advantage of all the functional forces applied to the dentition, including the forces of mastication, because most of the times twin blocks are fixed. We do not give removable twin blocks. We give fixed twin blocks because the child has to chew, eat, swallow, drink, do whatever he wants with respect to his oral cavity with the appliance in its position. Because these forces, these are the ones which are going to bring about the modifications. So these are the indications. We can indicate it any class 2 D1 malocclusions with an overjet of more than 10 millimeters. Growing age groups, class 3 malocclusions, we can give reverse twin blocks with an anterior open bite, deep bite. This is one of the patients which we corrected, where you can see the retruded mandible. You see a deep mentolabial sulcus. There was a hyperactive mentalis activity. The mandible was retruded. This was what we achieved in a period of 2 to 4 weeks. Okay, the pterygoid response was fantastic because the patient wanted full time, performed all the activities, and this is the kind of mandibular protrusion that we achieved in this patient within a span of 2 to 4 weeks. And then there will be a retention phase. You cannot indicate a twin block in a dolichocephalic patient. Like I said, most of the functional appliances are not indicated because they are known to increase the lower facial height. So be very, that is where your facial analysis or in your photographic analysis comes to picture. And of course, you need to have a positive VTO. The contraindications include, like I said, vertical growth pattern, or in children where they're having severe crowding, because you might not be able to adapt and fabricate a proper twin block, and in patients who have a negative VTO. The most important part for a twin block is the bright registration. Very, very important. Usually in a patient who's having a 10 mm overjet, we try to do it in stages. We do not do the mandibular advancement at one stretch, like 10 mm at one stretch, we do not do it. Initially, we do around 5 to 6 millimeters. And then the second phase, we do it around another 4 millimeters. Now, when you take the bite, we need to see that the overjet, that's an initial advancement of 7 mm. And then once that is achieved, we again reactivate it to another 3 millimeters. When you do the bite registration and place the 2 millimeter wax in between the teeth to achieve the bite, you need to see that the interincisal clearance, that is in between the incisor, should be around 2 millimeters. In the first molar region, it should be around 5 to 6 millimeters. And again, in the molar region, it needs to be around 2 to 3 millimeters. We want more space here because our bite blocks are going to be here. So whenever you do the bite registration, you need to achieve this. Only then you'll be able to fabricate a proper twin block. By doing this, what is happening? We are also trying to bring the mandible forward. These are the components. You have the occlusal bite blocks, you have the delta clasps, you have a labial bow. So every component can be made active. You can also achieve, in a class 2D1 where there is proclination of anterior teeth, by activating the labial bow, you can also retrocline the anteriors. Lower also you can have a labial bow if you want, where you can slightly retrocline the lower mandibular anteriors as well. You can also incorporate the jack screws or high axis screws, to bring about the expansion. Also, there is a constricted maxillary arch. The expansion as well as a mandibular prognathism can be brought together simultaneously. You don't have to wait for expansion to happen and then give a twin block. No, it is not required. So that could be that could be one of the so normally we see that the occlusal inclined planes are placed at an angle of 70 degrees. Okay, it should be angled from the mesial surface of the second premolar or the distal molar, in case if we are using it in an early mixed dentition stage, at 70 degrees to the occlusal plane. Of course, initially it was 45 degrees. Now it is changed to 70 degrees. And you see that buccolingually it covers the occlusal surfaces of the lower premolars or the deciduous molars to incline with the inclined plane of the upper twin block. So there is a bite block on the upper teeth as well as the bite block on the lower teeth. On the lower, it is the premolars which is covered. On the upper, it is the molars which is covered. And this angulation is at 70 degrees. When you look at the phases of treatment, you have 3 phases. One is the active phase, the support phase, and the retentive phase. Active phase is when the appliance is worn full time. Like I said, the patient has to wear it throughout the day. Especially when he's chewing, swallowing, everything, it needs to be in place. The main objective is to correct the arch relationship in sagittal, vertical, as well as in the transverse dimensions. And when the patient is wearing it full time, we need to see and appreciate the pterygoid response, which we normally see between a period of 2 to 4 weeks. Then once we have achieved that pterygoid response, that is the mandible is brought forward, the child is not able to take the mandible backward, we have achieved the pterygoid response, we need to start trimming the bite blocks. Okay, in case of deep bites, class 2 div 2 malocclusions, we can start trimming the upper bite blocks at a rate of 1 to 1.5 millimeters per month. Okay, so that is why the twin block therapy goes on for a period of 6 to 9 months. Now, what is the basic funda behind trimming these bite blocks? Once the bite has been, the mandibular protrusion has been achieved, by trimming the upper bite blocks, we are trying to allow the extrusion of the the posterior teeth. Thereby, we are trying to achieve the occlusion so that the mandible will not go backward. That is the main objective. So that is why we try to do every 1 to 1.5 millimeters per month. In case of anterior open bites, the posterior bite blocks are untrimmed. We allow the anterior teeth to erupt, that is extrusion of the anteriors to take place. Now, once we have achieved the 3-point contact of the incisors as well as the molar regions, that is the end of the active phase, the sagittal relationships usually are overcorrected. We try to achieve an edge-to-edge bite anteriorly or slightly that is the normal overjet can be established. And we see that the molars are in a class 1 molar relationship. A class 2 molar relation is corrected to a class 1 molar relation. And then we have a support phase where we can always use a suede appliance, which is nothing but an anterior inclined plane with a labial bow. It also helps in retention of the achieved occlusion for a longer period of time. So this can be full-time wear again for a period of 4 to 6 months. That is again and when it comes to the retention phase after the support phase, which is after 4 months, we can tell the suede appliance. This is a suede appliance, okay, where there is an anterior bite plane. The patient can wear it only at night time, maybe say for around 6 to 9 months. So if you look at the overall treatment time, the average, the active phase is around 6 to 9 months. The support phase is another 3 to 6 months, and retention is another 6 to 9 months. On an average, you might require around 12 to 18 months, depending upon the growth of the individual, growth potential of the individual, how soon or how well the child adapts to this particular appliance, the wearing of the appliance, etc. These are some of the modifications. Like I said, you can always incorporate a screw in both the upper as well as the lower fragments to bring about the expansion of the arches. Now, this is what we try to achieve with the twin block therapy. That is, there will be an overjet reduction. There can be retroclination of upper incisors, proclination of lower incisors. The buccal segment gets corrected if you're incorporating a jack screw in that. A lower molar will erupt in a proper anterior and superior direction, thereby establishing a normal class 1 molar relationship. These are the advantages where there is a better vertical control. The facial symmetry is corrected. Depends upon, of course, the age of the treatment, because we are trying to do it at a very early stage. You can integrate it with fixed appliances as well. And it can also be used in the treatment of TMJ dysfunctions in case the child has, and it is always comfortable to the patient. Unlike your Frankel or activator or bionator, which are bulky appliances, twin block is a simple appliance where the patient is at comfort of wearing it. Aesthetically also it is good because it is at the bite blocks and the posterior. Anteriorly we cannot see anything. It helps in maintaining the normal function. The child chews, eats everything with the same appliance, so the functions are not altered. And definitely the clinical management and arch development also happens. The next appliance is Bionator. It was developed by Balters. This was mainly developed to overcome the bulkiness and the nighttime wear of the activator. Now, activator, nobody uses it. It is out of, most of them do not practice at all. Even in, I think in colleges also now, activator is not widely used because there are way other appliances that are available now. And the philosophy how Bionator was developed was everybody, like I said, most of these myofunctional appliances were only developed because those people who developed believed that it is always the equilibrium between the tongue and the circumoral muscles, and these muscles can be readapted and remodeled, thereby bringing about the changes in the bone. Please bear this in mind. If you understand this, you automatically will be able to identify what kind of a appliance I need to give to my patient. If the buccinators are, if the child is having a sucking habit because of which there is a constriction of the maxillary arch, you know that the circumoral, the buccinator is applying a lot of pressure. So you need to eliminate that pressure. So in that case, if it is a class 2 D1 malocclusion, in that case, you can always go ahead and give a Frankel's appliance, right? If it is the circumoral muscles are fine, it is just the mandible that is retruded, go ahead and give either you can use a Bionator or you can use a twin block. Okay, so that is why a proper diagnosis and a functional analysis with respect to the tongue and the circumoral muscles plays a very, very, very important role. I stress this all the time because we tend to forget the role of the tongue. We tend to forget the role of the musculature. We do not identify when the child is following a hyperactive mentalis activities that we forget to identify that. Tongue thrusting, we just see that child is following, tongue is placing forward. Is the tongue actually exerting a pressure? Whether it's a simple tongue thrust or a complex tongue thrust, we do not identify that. So that is very, very important. So functional space of the tongue is essential. And because of whenever we achieve this, he developed an appliance where the mandible was positioned anteriorly with the incisors in an edge-to-edge position. And whenever the mandible is positioned anteriorly, what happens is the dorsum of the tongue always comes in contact with the soft palate. And because of this, it helps to accomplish a lip closure. Okay. Any one of us, if you see who do not have major discrepancies with the skeletal malocclusions or with the skeleton, we see that we are able to achieve a proper lip closure. Unlike a child who's having a mouth breathing habit where there is always an open mouth posture, he's not able to establish a lip closure, or procline anterior, the lip closure cannot happen. There is some soft tissues which are playing a role along with the to bring about these changes in the skeleton. So the Bionator modulates the muscle activity and it does not activate the muscle. This was the basic philosophy behind developing a Bionator, that it just modulates the muscle activity. It the impulses are sent, the stimulus is sent in such a way that the muscle activity is just remodulated and it does not make the muscles active. It eliminates the forces that are exerted by the muscles. Also, it eliminates the abnormal and potentially deforming environmental factors. Now, these are the indications of Bionator therapy. Actively growing children for development, management of class 2 Div1 or Div2 malocclusions, in class 1 malocclusions with deep bites, in class 2 division 1 malocclusion in the mixed dentition stage, only under the following conditions, whereas contraindicated, again, like I said, vertical growth patterns, labially tipped incisors where we might not be able to fabricate a Bionator, and children with neuromuscular diseases or any special care children. These are the types of Bionators. I'm not going to discuss very much in detail because we might not be, fabricating these appliances individually. We definitely, myofunctional is again an interdisciplinary, like sir was telling. it is always, we need to discuss the cases with the orthodontist as well before we jump into conclusions that what kind of an appliance we need to give. Okay. So there are 3 types of appliances. One could be a standard appliance like this, which you can use it in a class 2 div 1 and a div 2 cases. There can be an open bite appliance like this, where you can use it in a case of open bite. There can be a reverse bionator, which you can use in a developing skeletal class 3. The last one is the Frankel's functional regulator, which was developed by Rolf Frankel. The basic philosophy behind this was he harnessed basically the buccinator mechanism and the orbicularis oris complex. He believed that working on these 2 is very detrimental in bringing about the changes. So he basically devised this. The Frankel's function was originally called as a gymnastic appliance, because he developed this to bring about to act as an orthopedic exercise device, so that it aids in the maturation, training, and reprogramming of the orofacial neuromuscular system. So anytime you want to give a Frankel's regulator or a Frankel's appliance, if you just give it to the patient, it will not work. Along with the Frankel's regulator, it is very important that you teach them some exercises which bring about the remodeling and the rematuration of these muscles. What Frankel's is doing is basically it is eliminating the forces and it has to remodel. How this remodeling is happening, it has to remodel based upon the exercises. If you're not teaching any exercises, any myo exercises to the patient, then you will not be able to see any changes, no matter patient wears it for 18 months, 1 year, 2 years, whatever. So Frankel's philosophy was based on his area of operation was on the vestibule only, where he developed the buccal shields, the lip pads, upper lip pads, lower lip pads, the lingual pads on the inner side. So all this was his vestibular area of operation, where he found that these shields are going to relieve the muscular forces that are being exerted on the dentition. So this particular appliance is usually placed or held in the maxillary arch. So based on which there could be a sagittal correction as well. Okay, the lingual pads that are present in the lower, okay, against the tongue, okay, on the inner side, will also act as a proprioceptive stimulus to aid in the forward positioning of the mandible. Because of this appliance is held in the maxilla, the lower teeth are free to erupt. So there could be unrestricted forward and upward growth, thereby establishing a vertical height. Okay. The periosteal pull by the buccal shields and the lip pads can lead to lateral expansion of the maxilla. There is minimal maxillary basal effect because maxilla is held tightly against the bone. So you cannot bring about major changes in the maxillary base, but the mandible can be brought forward again. So that is why the downward and the forward growth of the maxilla is restricted. So these are the different types you have. You can choose depending upon the kind of malocclusions that you see in your child. Okay. But again, like I said, without a proper myo exercises, none of these appliances will work. Okay, you need to do maybe slight trimming here and there depending upon as and when the child is wearing, maybe with respect to the occlusal grooves that you have placing there, or with respect to the buccal shields, the lip pads that are there, you need to make some changes. But again, it depends on, it is a very cumbersome procedure. Okay, with the fabrication of Frankel's regulator, the bite registration is very, very important. Like I said, for twin buck, it is similar to Frankel's 1B as well. Again, important thing to highlight here is whenever you want to give a Frankel's regulator, the impression that you take is very, very important, because it is the vestibule that is we are harnessing here. Okay, so your impression should cover the depth of the vestibule. So there are different trays that are available which cover the full vestibule, which extend till the vestibule. So those are important that you can use to make the impression, unlike your regular trays. If you're not able to cover the full depth of the vestibules, your Frankel's will not stay there, because it is mainly held by the tooth only. It is on the tooth and the tissues. It is not held by the tooth itself. Okay, so that is why it is very important for you to give a proper impression before you fabricate it. So the best therapeutic effect is achieved when it is used in the late mixed and the transitional dentition stages, where both the soft and the hard tissues are undergoing their greatest transitional changes. And most of the times we use Frankel's in case of a class 2 Div 1 malocclusions. The last one, which most of us use day in and day out without any concepts, without any proper understanding, is the myobrace. Myobrace, again, the basic principle is they try to the appliances are fabricated in such a way that you need to establish a proper lip seal, because they are all removable appliances. You need to hold the appliance by yourself, that is when you are able to achieve a lip seal. By achieving a lip seal, everything else is going to fall in place. Your tongue is placing upward, you're establishing from mouth breathing, you're going to a nasal breathing. A patient is having a thumb sucking because the child has to hold the appliance and it is covering against the anterior teeth like this. He'll not be able to place his thumb. So myobrace again has its own concepts. There are various types in that depending upon the various age groups. So you cannot just because everybody says T4K, blue one, red one, pink one, you cannot just go and use it just like that. Again, with myobrace, you need to use some myo exercises as well. So I call the myo exercises the oral gymnastics because we are playing around with the muscles. So the goals of these myo exercises is nothing but to promote a proper lip seal. We need to place the tongue and the palatal rest position. We need to establish a proper swallow and facilitate nasal breathing. And also they might help in correcting any dysfunctional habit patterns. So there are 4 major types of myo exercises. You have lip exercise, you have tongue exercise, you have exercises for the masticatory muscles, as well as a breathing exercise. Now, any patient who comes to me with a mouth breathing habit, now after having practicing myofunction for a long time, I tell them, please do practice the yoga exercise, the breathing exercises, the pranayama. Very, very important. It tries to help the child establish a proper nasal breathing. Also the anuloma and viloma, that kind of relieves any obstructions that are there, and the child will normally establish a proper breathing habit. From mouth breathing, a simple mouth breathing, it can go to nasal, we can reverse it. Now, in case if the child is having a short hypertonic upper lip, what you can do is ask the patient to stretch the upper lip over the lower lip without opening the mouth. Close the mouth and stretch the upper lip like this. So, and hold it there for 30 seconds and do it 15 to 20 times a day. So every time you are doing that, the hypotonicity is relieved. Okay. The upper lip will not be hypotonic anymore. There could be lip puffer exercises, which we call, where forcefully force the air or the liquid in between the upper and the lower lips and puff out the lips to the farthest extension and repeat it 5 to 10 times. That could also result in reducing the hypotonicity of the upper lip. You have the button pull exercises where the button is placed, held against, and that is we are trying to establish the lip seal, or holding and splashing of water, or asking the patient to drink every time he drinks water with a straw, or when the patient is sitting and watching a TV, give him a straw and ask the patient to sit. So by that, what he's doing, he has to hold the straw, he's trying to achieve a lip seal. One more thing that I saw when I went for a session, for special children, there was a speech therapist who came there. What they were trying to do is they were trying to give stimulation to the lower lip with toothbrush. What they say is the lower lip as well as the tongue has a lot of sensory neurons that are there. The sensory neurons are there, and by stimulating them, we can always achieve that particular lip closure as well. So before you do the closure of the lip exercises, you can always give massage to your lower lip and then ask the patient to do these particular exercises. Now, in case of tongue, we know the famous 4S and 2S exercises, where we try to teach the patient a proper swallowing pattern. We also have the hold pull exercise, where the tip of the tongue is made to contact the palate in the midline and the crest of the hard palate, and gradually the same position he has to open the mouth. Okay, the tongue should not lose the contact with the palate, and this might help in stretching the lingual frenum. So to conclude, whenever you want to think about intervening or intercepting or developing skeletal malocclusions with myofunctional appliances, very, very important is the diagnosis. Please, if you're not sure with your diagnosis, do talk to your contemporaries, do talk to your orthodontic colleagues to understand what is it that we are missing. Okay, and of course, when you want to give myofunctional appliances, like I said, because most of them are removable and the treatment duration is very, very long, patient and parent compliance is a must. Okay, and you also need to understand the objective of why you're using a myofunctional appliance. Just because a patient is coming with a retruded mandible, don't jump to give a twin buck. What is it that you want to achieve with that, right? That is very, very important. The name itself says myofunctional. We are trying to play around with the function of the muscles, right? So that particular objective, in spite of bringing the retruded mandible forward, if the circumoral pressure is not relieved, if the patient is still swallowing with a the tongue is not placed against the palate, you see still the hyperactive mentalis activity, then the objective is not achieved, right? So you also need to stress the importance of myo exercises along with the myofunction appliances. When all these things are taken into consideration, only then I feel that you can achieve what is it expected to achieve. So Edward Hangel, whom we call as the father of malocclusion, way back in 1907 stated that our best efforts are only to assist the nature, and that if we correctly interpret her wishes and intelligently assist her, she will complete the growth and development of these tissues normally in accordance with the type of the individual. So that the resort to mutilation that we normally do as individual practitioners is not a proper plan. The only goal and objective whenever we see a child with developing malocclusions is to assist the nature, because nature is already playing a role. Like I said, the chess game, one is us and one is the nature. Nature is always throwing its moves. We need to intelligently understand what that move is or what the next move can be, and then base our treatment plan. So whatever we can do to best assist the nature is very important, because we need to nurture the future. We cannot play. So it's always very important to think outside the box. Thank you so much, everyone, for patient listening. That's me, Dr. Veena Arli. That's my contact number and email. Anytime you want to share anything, any of your cases, please feel free. I could always be happy to assist you. Thank you so much.
Thank you, Veena ma'am. That was really brilliant and edifying session that you had about the topic myofunctional appliances. Now I would be calling upon Dr. Harsimran Singh Sethi, sir. I would just like to have his brief introduction. Dr. Harsimran has completed his graduation and post-graduation from Christian.
Excuse me, Prasanna sir. Prasanna,
yes, sir.
I guess there are one or two
questions.
questions.
Yeah, there are a few questions right here.
If you can take one or two
yes,
questions.
Yeah.
Thank you.
Yes, there is one question.
Yeah, there is one question that says that can you throw some light on lip seal and lip trap and its significance? Yeah. See, whenever lip seal, like I said, is very, very important, because whenever the patient is achieving a lip seal, that means to say what? His teeth are well within the jaw. That is, alignment is okay, though there might be some crowding and everything, but it is on the arch. Okay. The lip activity, the mentalis muscle activity is fine. Okay. And the it is not that is, and the tongue is postured properly. Okay. If we are not able to, if say for example, if you see a child with a mouth breathing with an open mouth posture, whenever you ask the parent when the child is watching the TV, how do they sit, or when you see the child sitting on a dental chair, they always sit like this with an open mouth posture. Okay. With an open mouth pause. With an open mouth posture, and the tongue is always placed in between. So when the lip seal is not there, what happens? The tongue is again unhindered. There is no inhibition for the tongue. So the tongue will always play a role. Lip trap, of course, what happens? Because the upper anteriors are proclined, the lower lip trap is happening. So in these cases, what you can do is a simple appliance or myofunctional appliance that we can give is a lip bumper. What is it trying to do every time? Of course, you need to correct the upper anteriors. The proclination is there. But sometimes what has happened, the child might also develop a lip sucking or a lip biting habit, and there might be a lip trap. So relieving the lip trap is very, very important here. So in your appliances, like I said, if you can, that is a case of a Frankel's class 2 D1 malocclusion. So you can give a Frankel the appliance for that particular thing, where there are lip pads also, where the lip is held away from the tissues and the child will not be having that particular lip trap always. So thereby what you're trying to do, you are trying to relieve that the lip pressure against the upper anteriors and against the lower anteriors also. So that can again help in bringing the mandible forward. I hope I've answered your question, Dr. Swapnil. Is that all, Prasanna? What is your opinion in cases of developed true class 3 malocclusions in file? See, with respect to true class 3 malocclusions, it is very, very important for a proper diagnosis. See, class 3s can usually, most of the times what we see, we think that class 3s are only because of overdeveloping mandible, right? Sometimes the mandible might be normal, but it could be because of the, retruded maxilla or developed maxilla. That is what we need to understand. Now, if that is the case, where it is because of the normal mandible is normal, but it is because of the retrocline or retruded maxilla, then you have to pull the maxilla outside. And 5 years is a very good age because the maxilla is still growing. The maxilla grows to its peak till 8 years. So if the maxilla is hypodeveloped, it is because of hypomaxilla, then you can also use the orthopedic appliances like your headgears, or the protraction headgears to bring the maxilla forward. And then you need to change. But if it is, the maxilla is normal and it is because of the mandible growing forward, chin cuff would definitely help. But again, word of caution, because most of the class 3 malocclusions cannot be corrected with myofunctional alone. Even if you hold the mandible for some time, it still tends to overgrow, so it might go in for a surgical. So always a word of caution for true class 3 malocclusions whenever you're treating true class 3 malocclusions. But like I said, skeletal, it's very important. You need to analyze what is it that is playing a role there. Is it the maxilla or the mandible? If it is the maxilla, a 5-year-old child, very good. Go ahead with the protraction face mask, protraction headgears. That is going to help you. Is there anything else? I think that's all. Prasanna?
Yes.
I think
Dear participants, if you have any question right now, you can unmute yourself and go ahead with your questions. Ma'am, I feel we are done with the questions.
Yes.
Yes. Now we will be shifting to this session, last session of this program by Dr. Harsimran Sethi, and I would like to have a small introduction to his career. He has completed his graduation and post-graduation from Christian Dental College, Ludhiana, and he has a dedicated consulting practice since 8 years in the field of pediatric dentistry. He is on board for various hospitals of Ludhiana like Fortis Hospital and Lifeline Hospital, and he is actively involved in research and has publications in various national and international journals. He is presently Honorary Assistant Secretary of IDA Branch, Ludhiana, and he is his keen area of interest is clinical pediatric dentistry, practice management, behavior management, development and malocclusion, and pediatric orthodontics. He's presently working as an associate professor at Department of Pediatric and Preventive Dentistry at Daswani Dental College, Kota. And Dr. Harsimran will be speaking about 2x4 appliances and their modifications for pediatric orthodontics. Over to Dr. Harsimran. So please start with your presentation.
Hi, first of all, I'd just like to check am I audible and all. Sir, could you please confirm me if I'm audible? I'll be visible from 2 areas. I just have the
yes,
same
sir,
so I hope all of you are able to go ahead. So first of all, thank you so much, MIDSR, the whole team, starting from principal sir to the whole of the pedo department, and especially the whole of the management team who have worked so hard for organizing this seminar and going ahead with the whole of the discussion part. Before I just start with, it's usually like, when you take classes and all, after 2 lectures, we're supposed to give a break to the children, and that's what I'm feeling right now, that after so much of education, if I just start the thing directly, it'll be too much, but that's okay. So for the protocol purpose, just before we begin with it, I would just like all of you to just recapitulate your memories with one thing. I hope all of you have read oral pathology and heard about the word syndrome. Right, syndrome is where one thing leads to the other, and this thing keeps on happening. This is nothing related to my topic as of now. What we're going to do is, I was just trying to correlate the whole webinar series that we are having. Like we all know about the Pierre-Robin syndrome, where a small mouth leads to the tongue being placed forward, and then the cleft palate happens. So similarly, what I am trying to put over here is like Dr. Umal Doshi's seminar. He talked about interceptive orthodontics at the beginning, then moving on to Dr. Veena, who talked about myofunctional appliances, and now I am the left palate part, which is left over. So talking about my topic, we'll be discussing 2x4 appliance primarily in its modified form. There are few reasons to discuss the modification per se. Just because why we are discussing the modification is because like the whole purpose for me, because you'll always have an alternative, right? So if we move on to the introduction, right? Thank you so much, Dr. Umar, for giving a good detailed talk about the importance of intersection, right? Whenever we have a problem, beginning to it up, so the interception process has to begin with, so that the malgration doesn't become that severe. It is not just that the orthodontist. Many times we will think like there are even all of us are facing this problem that the refer the child to the orthodontist at the age of 13 or 14 years, right? So that the whole ortho treatment can be done and all those things. But the main problem that we talk about even after orthodontic treatment is retention. Right. So I don't say that with a 2x4 appliance, your retention gets improved. No. But if you are growing in a physiological manner, that is one very important thing which I want to emphasize on. If you are growing in a physiological manner, your body will tend to adapt to it in a very nice manner. That is one very important concept that all of us need to know regarding interception, and that has been very well summarized. So not moving much into that, we'll be moving on to the other thing. We'll be talking about the disadvantages of removable appliances, like Umar sir already talked about the anti-rake crossbite, right? So that is the primary indication which I have for the 2x4 modified appliance. I'll talk about that. So the major disadvantages of removable appliances that we talk about is that the children don't wear it, right? Then the parents will come and complain that the children's child forgot the appliance in somewhere in the tiffin box, in the school bag, and then it's not found or something like that. So the whole treatment becomes a little bit cumbersome, right? So more importantly, some of those appliances are really a little bit of really present a difficulty in bearing those appliances. We all know that, right? Importantly, they require a little bit of cleaning of the appliance on a regular basis, then activation, then frequent dental visits. All of them are there for the other for the things that I'll share also. But still, those removable appliances, they do have a side effect, and eventually it's not that they don't work. They work very, very nicely, believe me. They will serve all your purposes, but you need a very cooperative child, which is a rare entity nowadays. That's what is my objective of coming to it. So primarily talking about the upcoming alternative, that is 2x4. 2x4 appliance, as all of you would be knowing as of now, the 2 stands for the 2 bands that we have to adapt into the molar region. Primarily, we'll be talking about only the maxillary thing, because mandibular, we'll come to that why don't we do much of the work with 2x4 in the mandible, because mandible is more like a self-correcting thing. I'll say that mandible tends to correct, or the mandibular teeth, if given the space, they will tend to correct at the right time. Right. So yeah, in talking about the upcoming alternative, we have the 2x4 appliance where we adapt 2 bands, or you can use the recent alternative that we have, the molar tubes, bondable molar tubes. It is less cumbersome, right? If you are going into the conventional 2x4 and 4 brackets onto the anterior, or 6 brackets, or maybe the 8 brackets, depending upon how many teeth are available. Like the main thing is going to take a help. Believe me, we're going to take the help of fixed orthodontics to a minimum degree. First of all, to a minimum degree, we're not going to cause a beautiful alignment of the teeth and all. No, nothing like that. We are here just to support the growth. Right. So if you all of us know, again, coming to the importance of intersection, that if there is a cross bite, it can restrict the growth of that specific jaw, especially if we talk about the maxillary jaw, which is the main jaw, right, which controls the mandible also. So the problem with the mandible is it's a contained arch, right? If the maxillary tooth, it comes out, right, it remains inside, it can restrict the growth of the mandible too, which we call as a lockjaw. All of us know about that, right? So moving on to the main advantages of using the 2x4 appliance. This appliance allows rapid correction of many incipient malocclusions in a single short phase of fixed appliance therapy in the early mixed dentition stage, right? The early mixed dentition stage provides multiple amount of benefits. The bone is very pliable. We'll be talking more about the maxillary bone only, again to emphasize, because the mandible self-corrects with the treatment modality that we are going to talk about. The versatility of this appliance permits to resolve various problems affecting the upper incisors in a simple manner and in a relatively short period. Again and again, we are focusing on one very important point, that let this appliance be applied only to the maxillary arch, and very few indications where it will be applied to the mandibular arch, where the mandible is not, allowing itself to correct only and something like that. And because we're talking about the early mix dentation, majority of the cases will be solved about using this appliance. Right, so it offers more effective and efficient tooth positioning, and it allows three-dimensional control of the involved teeth during correction of anterior crossbites and aligning ectopic incisors and rotation. So primarily, this is what is the indication for the 2x4. Do not go for an overcorrection. Do not try for what do you call it, the hero therapy, right? Being a hero or being a, trying something sci-fi in this case. 2x4, restrict yourself only and only. That is my opinion as of now. We might have a further research and we might get into it. There is a reason for that while we coming. Well, why I am talking about this. Restrict yourself only to correction of anterior crossbites, which will restrict the growth of the jaw for sure, as well as aligning ectopic incisors as well as rotation. Because again, when an incisor is ectopically erupted, when there is a V-shaped growth of the maxillary arch, right, or V-shaped incisors are present like due to some sucking habit or something like that. What happens is it restricts the growth of the mandibular arch, and if you correct that, automatically the mandibular teeth get displaced and they move, right? So primarily restricting it is very important. Again, like Dr. Veena also mentioned, like whenever you're choosing an appliance, it is very important to diagnose correctly, right? Moving on, we'll be talking about some more advantages. Evidence seems to suggest that a short course of orthodontic treatment in the mixed dentition may improve function and aesthetics and remain relatively stable once the appliance is removed. May remain relatively stable. Okay, so 2 or 3 important points just from this telling is this thing. Short course of orthodontic treatment doesn't necessarily refer to rig fix treatment. First of all, it can be removable. We should go on for the removable thing first, because that is much what I'll say into the finances thing also easier for the patient, because when we move on to fixed therapy, we'll be charging a little bit extra. So the important thing is that for the short course of orthodontic treatment in the mixed dentition and may provide function and aesthetics. That is very important. Of course, when you have a crossbite, function and aesthetics are compromised and will be relatively stable once the appliance is removed. So now primarily coming on to the issue is, if you have a crossbite, there will be no dentition which is spaced and where you will have a crossbite. So automatically, the first thing that you will have is space creation will be the major issue. Because of the space creation, all the problem would have happened, the anterior crossbite or also primarily the focus that we will have is on canine extraction. Right, all of us have heard about this thing that when your lateral incisor, majority of times when the lateral incisor comes into the arch or out of the arch, usually when it comes inside the arch, I hope all of you have read about this thing in your orthodontic lectures and all. So when the lateral incisor, the permanent lateral incisor, when it is erupting inside the oral cavity and it destroys the root of both the lateral and the canine from the deciduous dentist, this is a clear indication of arch length tooth material discrepancy, true arch length tooth material discrepancy. So majority of the cases that we'll be talking with 2x4 are usually such cases of arch length tooth material discrepancy. And so of course, space creation becomes one of the major things in them. Importantly, when we talk about canine extraction in primary, for the primary teeth, it has to be bilateral. The important thing is it has to be bilateral. It has to be done in both the sides. There are alternatives to this where we'll say that we can slice the canines and then proceed with the treatment. But again, there are certain controversies to it, which as a clinician, it will be very difficult for us. If you have to slice half of the canine, then why to preserve it? If you have to do a root canal for the canine, why to preserve it? Little bit of slicing. In such cases, you usually do not need 2x4. 2x4 will require significant amount of correction, and hence canine extraction becomes really, really important. And it is not at all, first of all, it is not at all necessary that if you require one canine extraction, it will serve the purpose. No, it is not like that. You have to extract both the canines, and the importance of it. I'm talking about, start with the importance of this. See, single canine extraction will provide space on one side. Body is very smart. It will tend to adapt in the space which I got. What will it be leading to? It will lead to something known as a midline shift. So your orthodontist later on will say, that is the problem. So that's why bilateral canine extraction becomes the most important. Even if you have a midline shift, do not believe in that. You have to go for a bilateral canine extraction. Bilateral canine extraction will give you adequate amount of space, and you are, proclining the incisors or doing the necessary treatment. You will be providing space for the treatment. And importantly, what will you do is you'll increase the arch length for the patient. Once you increase the arch length, it gives you more space inside the arch and allows you for better treatment. So some of the components, when I begin my lecture over here, when I heard, when I was talking about this thing, so I think it was when I was hearing Dr. Omal being a certified orthodontist and such a nice person. So I think it was going on in the reverse manner, that he should be talking more about the ortho part and I should be talking more about the pedo part, me being a pediatric dentist. So some of the components, coming on to the components for the 2x4, we have braces. So these are the brackets that you can use for this thing. Then we have wires and certain amount of other things that we'll talk about. So primarily talking about the braces, we'll be talking about the braces fixing part and all those things a little bit into the clinical part of it, only restricting myself only to the 2x4 thing. So for a brace, just an introduction, they have a wing, they have a slot. Clear? So this is one thing. When you talk about braces, you can have normal braces, you can have mini braces, they will come in specific sizes. The only difference in the normal and the mini braces will be the size of the slot. There is something known as the ROS and the MBT. So this is one thing which confuses us while we are going to the things majority of the time. So important to understand is all these category of braces, the ROS and the MBT that we are using. Okay, again, regarding the orthopedics and all those things, for you guys, it is a completely separate study altogether. We are talking something in the very initial stage, which can be done as well as learned easily, as well as resolve a problem of the children on an easy basis. So ROS and MBT, primarily one thing that you need to understand is that they have a pre-adjusted tip and torque, which is incorporated into the brackets automatically. Okay, just understand this thing as of now. I will be talking about this thing in detail. They have a pre-adjusted tip and torque that is incorporated inside the bracket already, right? So this is how the tip is incorporated. If you can see over here, we have something known as, in the first figure that you see, and over here. So if you see, there is a tip into which the bracket is bent. It's not the wire which is going straight through the bracket. It's going at an angle, right? So the torque is being represented in the second figure, right? What is the mesodistal inclination of the crown is the tip. The labial angle inclination of the root as well as the crown is what we talk about in the torque. And the in and out position, of course, if you have a straighter bracket, you'll keep it over there and you can shift it outwards inside. That is it, right? So torque is the second thing that we have, which will adjust your roots accordingly. The tip will adjust your canine inclination. So one thing is clear, we have to place the bracket at a certain location, right? And then put our wires, which will do something. Okay? So the thing is that the brackets will autocorrect the anomaly. Moving on to how do they correct it? We'll be coming on to the wires, but I have talked to you regarding the slot, right? So just imagine whatever is the size of the slot. If I give you a wire of the same dimension, and if in this figure, if you can see that there is a protrusive tooth, like this protruded in a further angulation. Once a specific type of wire goes inside that slot, automatically this tends to be properly angled, right? So now we'll be talking about more of the wires also, but before that, just before we go ahead with the wires, a little bit the fixing of the brackets onto the tooth, the different multiple amount of areas that we have to put. The size, the length of the incisors are to be marked, and the height of contour of each tooth. That is important. We, all of us BA classes dealt with the height of contour. Height of contour is basically the maximum mesodistal as well as the cervicoincisal depth that we have. So you have to select that. The intersection point is where you have to apply your bracket. Importantly, then moving on to when you fix all the brackets, a little bit of description. But the lateral bracket, of course, there is a position for the rest of the brackets also. But the lateral bracket supposedly should be 0.5 mm placed below the level the central incisor is placed. This is based on your orthodontic, the prosthodontic concept. When you do a little bit of teeth setting, you'll be remembering that time that your lateral incisors are 0.5 mm above your central incisor. When we talk about the wires, you'll come to know why do we do that. So just this thing, that there is a tip and torque which is incorporated in the brackets, and we need to place the bracket in this position. Importantly, over here, what I'm showing is just a case where it is all in front of you. The problem is when you talk about dealing with cases of rotation, when the tooth is rotated, finding out the center and applying the bracket in the center becomes a big job. And then again, fixing the wire also in that becomes a very big job. So before we move on to this thing is, I'll be just taking one or two clinical tips for you all guys. There are two branches of people that I talk about, orthodontists and pediatric dentists, where the etching time for us is not the usual etching time. Believe me, the first thing that we always do wrong is go with the etching time. The normal etching time for any kind of other composite restorations, these are attached with the composite only. So the normal etching time for any kind of composite for the tooth, we usually keep it to 15 seconds. This does not apply to orthodontists as well as pediatric dentists. We'll be coming to that. The problem, let's talk about the problem. So what is the problem? First of all, before you have the tooth, it's very important to clean the tooth with your scalers first to remove the layer of the salivary pellicle which is there, and it doesn't go off by just three-way syringe or the air pressure of that. You have to do a properly scale the surface where you're going to apply the bracket. It is very important, right? The next step is etching of the tooth. So how much time do we etch the tooth? It is usually 30 seconds to 1 minute that we etch. And the reason for that is there is a layer of aprismatic enamel which is usually present over the tooth which are ungrounded. When you're doing a composite restoration in a class 1 or you're doing a class 1 cavity for a grounded tooth where you have prepared a cavity, you remove the top layer of the enamel. That is usually the grounded enamel, right? When you talk about the ungrounded enamel, which is present usually for the orthodontist as well as for the pediatric dentist, not while preparing a cavity. The pediatric dentists do this for the pit and fissure sealant. Again, for the pit and fissure sealant, we have a surface which has ungrounded enamel, usually ungrounded enamel if you not remove the pit and fissure, minor pit and fissure gain. So the problem happens is when you're trying to bond to these surfaces, it is very important to etch for a longer time, right? So that's what is our recommended time. That's what is our recommendation. We should go for 30 seconds to 1 minute etch, right? Moving ahead, again, removing the edge from the surface is a completely different task. 5 seconds means 5 seconds of water irrigation. It is not just you should, just remove the blue color thing from the top and move ahead with the next thing. No, you have to etch it nicely. After etching, you have to wash the tooth nicely for 5 seconds. And coming to the next point is drying the enamel. Now, again, over here, we have two branches, orthodontics as well as pediatric dentists, where we can easily, apply, use your conventional thing of drying the tooth completely and seeing the chalky white appearance. That also only orthodontics and pediatrics should do. Why? Because we are the people where the denting will not be involved, and the sensitivity problem associated with the composites is usually for the denting purpose. So when you've grounded the enamel, it is not advised that you should dry it up solidly. You should dry it up very lightly so that the dentin doesn't get applied. You can apply a Teflon tape inside the cavity that will help you to protect the dentin. But being an orthodontist, when you're dealing with orthodontic principles, you can, you have the liberty of drying it up nicely, seeing the chalky white enamel being present and all this. Importantly, the composite that we are going to use, it is not the regular composite that we can use. I am so sorry to say that you have to invest in the inventory for this thing, as well as not your flowable composite. Please believe me, those two things are disasters if you talk about orthodontic composites. Even the orthodontic bonding agent will be more of a primer thing. So primarily buy the specific things. There's an orthodontic primer which needs to be bought, or if you have a bonding agent nowadays which is universal. Why do I say this thing? Is because the normal composites are supposed to bond the tooth with the material, right? So that is what is the bonding. Over here comes another thing, the bracket. So over here, you're trying to bind the bracket with the tooth, with the bracket containing a silane component and all those things. Your normal bonding agents would not work. And similarly, your normal composite would not give you the best of the bonding. So hence, you need a separate bonding agent as well as a separate composite for both the purposes. So moving ahead, once you finally place the bracket, the in and out position, importantly, press the bracket completely inside so that there should be no space between the bracket as well as the tooth that should be present. So 3 principles: the bracket has a tip and torque incorporated. Then the next thing is when you press the bracket nicely, the thing should happen. Next, moving on to is the wires that we have. We have a set of night eye wires. You will be what series? This is what the series I follow. Majority of the orthodontists might not be agreeing to it, but the night eye series 012, 014, 016. This is good enough for the initial purposes, and then we have a stainless steel wire which is 1725. Right. So talking about these wires, what night eye all of us know, nickel titanium wires. The important role for the night eye wires is that they have a shape memory as well as they are super elastic. Right. So that is what is the property that I was talking about since the initial phase. That is, they have a shape memory and they are super elastic. So you can flex it up in any condition. It will come back to its original position. That is what we mean by shape memory. So if it is available in a preformed round wire pattern, right? So you just need to put that wire inside the component and it will derotate your tooth automatically. Right. So just a brief description of the wires, that what is a round and a rectangular wire. You can see it in the cross section. Over here we have a round wire and over here we have a rectangular wire. Now coming back to the initial figure, I'll just take you back some slides over to this position. So imagine if you have a tooth like this, and if you put this wire, which has a shape memory as well as is super elastic, so it will go inside, get the tooth easily like this, right? The problem with rectangular wires is they do put a huge amount of force onto the brackets. So initially it is very difficult to place a rectangular wire. So hence the series that we follow is usually we're placing a very light wire like an 012 wire. One thing that you need to understand is what will a round wire do that a rectangular wire, what will a rectangular wire do that a round wire cannot do? You know, I talked over here that if you can place this wire over here inside, it will get this tooth over here. So automatically this thing is clear now. If you place this wire at this level in this situation, you will not be able to because your bracket will tend to debond if you place with such a high pressure. So what you need to do is you need to place your 012. 012 is a very simple wire, very thin wire. Okay. So what will that wire? Just imagine this rectangular slot and a round wire inside that slot. What will a rectangular thing? It will move on its own. So it will cause only the tipping of the bracket, right? So it will cause some partial movement. And when you put the rectangular wire in this position, it will provide you the necessary torque. I hope everyone is clear with this thing. So moving ahead, we have the specific amount of specific wires also, where you can have a rectangular or a round wire which will do their specific purposes. And the series that you usually follow for treatment is first you go on with the 012, then you move on to the 014, 016, and you will realize the importance of each and every wire as when you keep working with these wires. Stainless steel wires, again, they do have a major role. It is important to give a 1 month period for these wires, and importantly, it is like one very important question: after how many days should you change the wire? Take your time. Let's give the time to the patient. Okay? It is like you'll have the effect of an 012 wire within 3 days also sometimes. You know, the earliest case of 2x4, I think I corrected it. There was an anterior crossbite case. It got corrected in maybe 5 days. The crossbite was corrected. But still, that is the time when you need to tell the patient that, dude, this is the time you need to continue with the treatment. It is not over as of now. That you need to complete the treatment, you need to complete the whole series of wires, and you need to understand that each of the wires has a specific purpose. So hence, you should go ahead with the treatment. At time of changing the wire, it is more than 1 month, not just some of you would recommend 21 days or something like that. Give it a more amount of healing time. You know, the healing time means when you cause the tooth to move, there is some kind of changes that happens in the soft tissue around in the periodontium. You know, a little bit of over application of force, hyalinization. Let it settle down. The results will be as beautiful as slow you proceed with the treatment. Not very slow also, but yes, maybe around 1 month, 15 days is a good 1 month plus 15 days or 10 days or 5-7 days is a good time that you should give to sleep. So now the next thing is, what else do you need apart from the wires and the brackets? This is a set of modules that you will need to fix the wire into the brace. Again, you have the molar tube. These are the bondable molar tube if required, because when we talk about the modification, that is what is the major thing. We will not take anchorage from the molars. This is what we are going to discuss today. The 2x4 modified appliance does not contain any kind of molar anchorage, and without that also we achieve results while treating patients. So of course, you know, right? The most important thing is if you don't place the bracket, still your wires are causing the required amount of movement that you need. So what is the advantage? Your appliance becomes less cumbersome. When the appliance becomes less cumbersome, you'll have more of your patient cooperation available. Then you need a certain amount of e-chains to be present, right? We don't go for all of them. Primarily, I'll go for either this, the one which has a space in between. We call it the long chain, or you can have the short chain. The long chain is for initial kind of movement that you see. When you achieve the final result and there is spacing that is present inside that to close the teeth, to approximate the teeth together, that is where you will need your e-chains to be present. And the arch sleeve. This is actually the arch sleeve. I think I have a, yes. So this is actually the arch sleeve. This is where you put the arch sleeve. Over here, we've talked about just this region, but again, when you talk about a 2x4, the arch sleeve should be from here to here. So what is this arch sleeve actually doing? This is just covering the wire, because in the conventional 2x4, like that is what I have faced as a clinician as a difficulty in treating my 2x4 appliances. Whenever you put a 2x4, there is a behind the lateral incisor, back and till the molar, there is a stretch of wire which is uncovered, and even when you put your O12 wire, it tends to come out, it irritates the patient, and all. There was a lot of problems. So what happened? It was accidentally only that we saw one time that the patient has cut off the wire only by himself because he was not able to attend, and then the result actually came. So this is how we went ahead with starting to treat cases with this kind of a format. Now, Blue Bite, this is something which is, I think, Anna von Stedman is an Indian-based company we have over here. So they have this thing. Blue Bite is basically a bite raising composite. Right? Bite raise is one thing that you will need because you have to unlock the lock. So in an anterior crossbite, if you have a crossbite and you think that you can just place your 2x4 appliance and even with the crossbite, this thing will be corrected. It's not possible. You have to open up the amount of the required bite that is there. Put the preferable teeth for me will be the maxillary molars. You should place it on the maxillary molars. Mandibular molars are also okay, but again, I will still recommend the maxillary molars, more stable, less amount of saliva flowing through, and it's easy to perform the treatment. So you raise the bite with your specific thing, and now this is something which is, all of you know, these are the ligature ties. We have also call them the Kobayashi ties. So what is the use of these ties over the modules that we have talked about initially? The purpose of this is similar to these modules, right? What does a module do? It fixes the wire inside the bracket. Now, this module is supposedly an elastic module. The problem with us is we will be treating teeth which are not straight. They will be angled into some direction over here, or there will be something like this. This is still manageable, but the rotation or a tooth which is behind as well as rotated, you will have a large amount of difficulty in placing your module. Still, if you place that module, right, we have a wire which is stretched inside the module, right? And that module being elastic doesn't tend the wire to allow to get completely locked inside. What we have discussed is that for our treatment to be successful, for the necessary tip and torque to be achieved by the necessary wire, we need that our wire should be locked inside the bracket slot completely. If it is an elastic thing, sometimes what it does is it doesn't tend to fix that wire completely inside the bracket. So for that, in some cases where there is an excessive amount of rotation which is present and you want it to derotate more, in such cases, we use the Kobayashi ties. Right? Importantly, we do not use the ties directly in the first visit. Let us go ahead with first the module. Okay? And once you are done with the module, there is little amount of movement which has happened. Right? Then you should move on to the ties. Importantly, there is some, even if you're putting the modules in the first visit, if you're talking, I don't have a picture right now to show you, but if it is a rotated tooth and it is difficult to put one module, right? So you can, there are two sets of wings that we have. One is the mesial wing, one is the distal wing. You can put two modules in one bracket. Right? That will help you to ease out a little bit comfortable for the patient. Go on to one module and in the next visit. Using the same wire, it is very important that when you change the wire, the amount of action that you need from the wire should have been produced. Right? If your O12 hasn't finished your wire even after 1.5 months, maybe it doesn't do it till the whole of the 2 months also, you need to move on to the ligature ties. These ligature ties will closely bond your wire to the bracket, and hence your tooth action will be caused. Important to remember in the whole of the 2x4 appliances, what we are doing is just using a bracket which has a specific amount of tip and a torque, and we are just facilitating a wire inside that slot, which will cause the necessary amount of movement to happen. Right, some instruments that you'll need is, first is a reverse tweezer. Please do not attempt these procedures without proper instrumentation. Reverse tweezer is very, very important. Why do we call it a reverse tweezer or bracket placing plier? Whatever you want, you can call it. In the normal tweezer, you close it, it closes. Over here, if you close it, it opens. If you can see in the figure nicely, so there is a gap over here. Once you close it, this opens. So it can help you to hold the bracket nicely. Please do not tend to do it with any other appliance. It is a little bit cumbersome. Then you need to you need to have something known as a wean guards plier. This wean guards, it helps you to place the modules it says that a bad workman usually goes with his tools, so preferably have the right tools. It is always better. Then, this line cutter or any kind of cutter for the wire. This line cutter was initially used when you have to cut the wire from behind the molar, right? But these three instruments will be very much handy. And apart from that, if you're using a Kobayashi tie, if you have to tighten up that tie inside the slot, right? For that, you will need your mosquito support. So being clear with the kind of treatment that we are doing, the kind of instruments that we are using, and the kind of cases we are going to treat, right? So this gives you a general outline for the 2x4 or the modified 2x4 appliances. Talking about the retention, before we go on to the cases, I'll be showing you some of my cases which we've treated. But as of now, these are the normal conventional methods of retention. Now is something which is very, very controversial for a 2x4 appliance, right? The thing is retention. You are talking about an early mixed dentition phase, right? In an early mixed dentition, if I ask you to place something like a lingual retention, you can place it, but there is a problem. What is the problem? There is going to be passive eruption that is going to happen inside the jaw. Your jaw is growing, your arch is growing. So when you bind two teeth together, it is going to restrict their movement. And one thing which I personally do not like is interfering with the natural process, right? So try to minimally interfere. So of course, even your clear plates, even if you're using a hard night guard as your retention plate, I would still not recommend it. The only thing which can be used nicely is your Hollies appliance. A well-adapted Hollies, again, this has, you can surely say that this does have a little bit of a restrictive effect. You can omit the labial bow also. Just the lingual plate, if you have a crossbite thing, so it will help you to retain the brackets over there. If there is a protrusive thing, then you surely need a labial bow also. So again, importantly, you can automatically, you can say that this might also restrict with the expansion of the arch, but yes. Importantly, again, this is usually for the cases which are usually V-shaped. If we talk about the other things, if we talk about an anti-way crossbite, what is the kind of retention we usually need for that? We do not need any retention for that, because once you've crossed the retention, once that lock has been removed, usually it will self-retain itself, right? Because the occlusion forces will not allow this to go back again. So that is the most important point. So these crossbites are usually self-retentive. It is a problem to place a retention appliance post-operatively, which is usually we can place a Hollies appliance carefully, right? Because again, we'll not have those amount of teeth also to be present inside the arch. So again, considering all these factors, again, we are restricting our treatment only and only to the maxillary teeth. Mandibular teeth, it's just simple. If you have a crowded mandible, you remove the canines, they will set, and then again, we are all masters at placing a lingual arch for them, guidance of eruption thing. So all those principles can be followed for the mandible, even if you're going for a serial extraction, so you don't need a lingual arch. Now, talking about some cases that I have for the correction of malocclusions, again, it's not 2x4 again, it is just my modified by 4 appliance, because we do not use the two brackets, will not be using the two molar tubes. So hence, talking about the first case. In this case, you can see that this girl actually presented with an initial problem with this thing also when she was 7 years of age. So this was corrected because she came initially with us, so we had the tongue bleed therapy given to her, so she got corrected with this incisor. When the lateral incisor came, again she had a problem. For this thing, because we didn't have adequate amount of retention with your removal appliances, a little bit of cumbersome procedure for her to wear the removal appliance. So we fixed it up and we got the necessary results with just placing 4 brackets as well as the wire components. Over here, you can see this is the final stage of treatment where we have placed a rectangular wire as well as an E-chain has been placed to close the amount of space. So there was no spacing over here. How did this spacing arise? Of course, when you place the wires, they're going to flare the teeth, so spacing will happen. Spacing might happen, spacing can happen. Depending upon the amount of flare that your wire is causing, depending upon how posteriorly your tooth was, you can have a little bit of spacing that is there, because when the tooth moves forward, when you're increasing in the arch length, even at a constricted arch like this, might give you a little bit amount of space. So once you have space inside the arch, you can easily close it up with your E-chain. Now, one thing that willing disclosure of E-chains, again, if the patient just like Dr. Omal clearly mentioned regarding the ugly duckling stages, this treatment is not for that case, please. In that case, the normal canine positions will get hampered. So hence, this is not for the correction of that. Again, if you have such a case, in such a case, the canines are already placed on the top. right? This is the usual arch alignment. So in such a case, even if you close the space and you have something like this, your canine will not get faulted. Right. So this is the final position that we have, and after the removing of the faces, this was the condition that we have. Now, yet another case. In such a case, I want you to specifically have a look at the lower incisors also. Right over here, we had a typical amount of anterior crossbite present with reference to the 2-1 being present, as well as this 3-1 also. What problem can the 3-1 face apart from this being crossbite is the periovation. You all know it is a big problem. Over here, what did we go ahead was, this is the patient initially after we put the wire. Right, initially just after we put the wire, the patient is closing like this. You all know why he's closing like this, because again, for the correction of the anterior crossbite, you need your bite to be raised a little bit. Now, once the bite is raised, you have to put the brackets at the required places and put the wire. Let the wire do its job. Right. So over here, the patient was not able to close because of the bite being present. As and when your correction happens, right, you need to remove that posterior bite raise that you've already done. What does that do is, you just ask the bite to settle down. So once the bite settles down, right, then your patient, even if the tooth goes back, it can only go back to the maximum amount of overjet that you have. It cannot go beyond. So your anterior crossbite cannot usually happen, because crossbites, we all have a rule that they cannot, after correction, they do not read any kind of retention also. Right. So this was another case where we have both the lateral incisors being locked behind. Right. So once both the lateral incisors are being locked behind, so what do we do? Again, this was one case which I specifically put because of the reason that many of us would be having a problem that if we are not using the molar, where is the anchorage coming from? This is the case which actually gave me also the courage to go ahead with 2x4 in many cases. But because what did we do in such a case was just place these two. And similarly, if you can see as I was talking about in the lateral incisor case, this lateral incisor could not be engaged properly in the first visit. I'm talking about primarily about 1, 2. Even the bracket was not placed in the center. In such situations, if you're not able to place the bracket in the center, it's completely okay. As and when you go ahead with the treatment, you can always and always alter the position of the bracket. It is not necessary to place the bracket in the center always. As you can see in this case, it was completely locked. If this lateral incisor was completely locked behind the central incisor, so automatically you do not have adequate amount of space. Again, this patient is in the occlusion stage because we raised the bite again. And these are the final results that we have. Over here in this case, one biggest confusion that I also had was, will the canine allow this thing to happen? It was just a chance which was taken. I was planning that if I'm not able to correct it, then I'll move the canine a little bit distally, shift the canine a little bit distally, and then try to get it down. So I told the patient regarding this thing. But again, when it came out to be really beautiful. Again, simple thing, keep it simple. The important thing that one problem that you can face in this stage that I'm specifically going to talk about is over here, because the lateral incisors were distally lingually placed, so you do not have that problem. But again, those wire ends, they can cause a little bit of trouble, right? And there is something which we usually call as heating the night eye wire. I do not recommend that, especially in such cases. Heating the night eye wire, it does cause a little bit of effect. The night eye-ness of the night eye wire is actually lost if you heat the wire. This is a property, right? So primarily, avoid heating those wires even from the ends and all those things. And what you can do for such patients, they will come to you the next day. I have a problem over here. So primarily in the first visit only, give them extra amount of wax. Okay? So that wax, you can place it over there. That wax is just going to cover the edge of the wire, tip of the wire. If that lateral incisor is outwardly placed. Over here, this doesn't trouble the patient at all, because in this case, it was lingually placed. If you have a buccally placed lateral incisor, in such cases, you might need to primarily give the patient a little bit amount of wax sheet. That wax sheet will, the patient can apply over there, and after 1 month, that thing will also be solved. As and when you keep on increasing the size of the wires, they will automatically come in alignment, and hence the patient's lips can get properly engaged. One thing which I want all of you to understand is, they will ask you, doctor, what are the post-operative instructions for after you put the braces? 2 more important things, which I specifically tell all my patients, is avoid 2 categories of foods initially, just initial. Like even if for ortho cases, we need to avoid 2 types of. I tell them, 1, do not eat pizzas and golgappe. Golgappe is, you can call it pani puri or that category of food, right? What I basically mean is cheesy as well as crunchy food. Cheesy and crunchy are two categories of food that I ask the patient to usually avoid for the first 1 or 2 months, right? And then again, once they know how the stitches, where the braces are placed and how to clean that initially, they can stop that out. They can start that out. So this is how it goes. So finally, we have a good treatment for this. Now, this case again, this is another case where the treatment was done for this lateral incisor, but as of now, we just got the lateral incisor outward in place. I want all of you, if it would have been an interactive session, I would have asked you to identify 2 mistakes, but I think over here I'll only have to tell you. So one mistake I already talked about is I've not placed this thing in the center, of course, because this is interfering, right? So hence it is not placed in the center. After this was moved out, I removed the bracket and placed in the center. And second thing over here was this removal of the canine. This canine removal has not been done because it's just an initial phase. It has to be a bilateral canine extraction whenever we are treating this case. So finally coming on to the conclusion, one of the keys to achieve a successful orthodontic treatment result lies in the hands of the parents as well as the pedodontist. It is very important to counsel your patients. Over here, the amount of cooperation needed from the patients is usually lesser than compared to your removable appliances. We all know this thing. Fixed appliances have this big benefit that we can usually keep the amount of cooperation that we require in our hands. But again, there can be, children can be very good to bracts, and if they are bracts and before inserting a pencil inside your brackets and all, nothing can save you. So again, you have to save yourself from such circumstances and go ahead with the treatment. Now, identifying a malocclusion at an early stage and diagnosing the malocclusion at the correct stage can can provide you good stability in the treatment results. One thing very important, as I talked about in my when I just started the presentation, that even if you have to proceed with the full orthodontic treatment also, this thing tends to relapse, right? So the problem is, if you have corrected it in an initial stage, if we have done the correction in an initial stage where the bone is still pliable, the bone tends to support the tissues, like we talked about the functional matrix theory, right? Functional matrix theory is one thing, again, which helps you for the retention phase also. What does the functional matrix theory say? That the position, support, maintenance of all the hard tissue is secondary, compensatory, and obligatory to changes happening in the surrounding soft tissue, right? So if we have caused a change in the hard tissue initially, the soft tissues are in the adapting phase as of now. So finally, when the tissues land in their final phase, this hard tissue change that we've incorporated at the right stage will definitely be accepted by the soft tissues because they have modulated accordingly. Thank you so much, everyone, for your patient listening. I'll be open to any kind of questions if we can solve it out as of now. Again, once again, a sincere thanks to the whole team of MIDSR for allowing me to present my bunch of knowledge in front of the elite delegates. Thank you once again.
Thank you, Dr. Harsimran. It was a really nice presentation and quite elaborative for the topic. Now I open this question and answer session for the present topic. Participants, you can unmute yourself and ask the questions. Any questions, participants? Okay, so I feel there are no more questions. It was interesting topic and people got a lot of things from it seems. Anyways, now I would like to hand over my mic to Dr. Mahesh Dadpe sir, who is professor at Department of Pedodontics and Preventive Dentistry, MIDSR Dental College, for expressing his vote of thanks for this program. Over to Dr. Mahesh sir.
Thank you very much, Prasanna. Good afternoon and all. It's my privilege to have an opportunity to propose a vote of thanks for this program. Firstly, I would like to thank our founder president of MIRS MIT Group of Institutions, Honorable Professor Dr. Vishwanath Karad sir, without whose blessings nothing of this scale would have been possible. I would also like to thank our managing trustee and executive president, of my SMIT group of institutions, Honorable Rahul Karad sir, who has been a constant guiding light throughout. I would also like to thank our Executive Director and Honorable Member of Maharashtra Legislative Council, Sri Ramesh Appa Karad sir, and our Executive Director, Honorable Dr. Hanuman Karad sir, for their blessings and constant support. I would like to thank MSDC Observer, Dr. Shailesh Wange, and MSDC President, Dr. Narendra Kale sir, for their guidance and support. I also extend thanks to our respectable principal, Dr. Suresh Kamble sir, and our respectable vice principal, Dr. Suresh Kangne sir. I would like to thank our HOD, Dr. Yogesh Kale sir, for his initiative and determination, which has made this program possible. I would like to express my sincere thanks to our esteemed speakers, Dr. Umal Doshi sir, for making preventive and interceptive and corrective orthodontics looks so easy. Dr. Veena Arli ma'am for excellent coverage on restoration of functional efficiency, and Dr. Harsimran Singh Sethi sir for putting light on preservation of aesthetic harmony. Once again, I thank Dr. Umal Doshi sir, Dr. Veena Arli ma'am, and Dr. Harsimran Singh Sethi sir for taking out time from your busy schedule and enlighten us with your knowledge and experience. Finally, thank you all the delegates and participants from all over India for supporting us by registering in such a huge number. Shortly, we'll send your certificate of participation to your respected email address. Thank you all once again. We'll conclude this program after Pasaidan. Dr. Srikant sir.
Piyusha
Thank you, everyone. We'll end this program here now. Thank you very much. We'll end the Zoom session.